were all members of a club no one wanted to join. Different backgrounds, ages, experiences. Thousands and thousands of us have been struggling for weeks and months with ongoing symptoms of COVID-19. These are some common symptoms, but there are many more. Some of us have been ill throughout, with others having relapses. We're still very ill. We're feeling pressure to return to work, to care for families, and get back to normal, when we still feel anything but. No one seems to be able to answer our questions or give reassurance. Will we ever get better? Will there be long-term repercussions for our physical and mental health? Is this post-viral fatigue, or are we still infectious? Will I be able to do the things that make me happy again? Can we hug our loved ones, or will we make them sick? Is this damage irreversible? Am I going to die? We just don't know, so we're sending out an SOS. Each of us has our own journey, but lots of us are feeling abandoned, dismissed, brushed off, ignored, and given conflicting advice. It can be hard for those around us to understand how ill we are. It's confusing and scary. Our numbers are growing and we need to be taken seriously. We need rehab, research, and recognition. We need to be believed, helped, treated with compassion, and supported by those around us. Please hear our SOS.
Good morning, good afternoon, good night to everyone. Welcome to the second day of this long COVID joint research forum by the GloPID-R and ISARIC. We had a wonderful and very important day yesterday, and I'm sure that today what you will be here will be very important on long COVID. Which is becoming, unfortunately, a big topic of research and of care today. Thanks to all the organizers for the organization of this day. To start, I wanted to first introduce Charu Kaushik, who is the chair of GloPID-R. Thanks, Charu.
Thanks very much, Yazdan. So good morning, good afternoon, good evening, everyone. Again, I'll reiterate what Yazdan said. Excellent discussions yesterday. It was so important to hear patient voices. I'm going to take 5 minutes of your time this morning just to talk to you a little bit about GloPID-R. Some of you may be aware of the organization, for others it may be new. So next slide. So GloPID-R is the global research collaboration for infectious disease preparedness. It's an international network of research funding organizations that was launched in 2013 by the heads of international research organizations. And the main goal for GloPID-R is to facilitate, accelerate, and deepen collaborations among research funders on emerging diseases. There are two main ways that we do this. First, by investing in preparedness research in between crises. And as we have done this year in 2020, by mobilizing resources to respond rapidly and effectively to infectious disease outbreaks and pandemics. I think we can add that to our list of things. Next slide. So currently, GloPID-R has 29 members from 21 different countries and 3 observers, including WHO, CEPI, and EDCTP. So we really are a global organization. Next slide. Next slide, Matt. Thank you. And just to quickly go over the goals, as I said, we bring together funding organizations that invest in research related to new or re-emerging infectious diseases, with the main goal of, first of all, research preparedness. And within that, we do a number of things in terms of exchanging coordination and collaborations, policy development, development of research agendas. Number 2, to do rapid and aligned funding by identifying priorities with WHO, other organizations, identifying gaps, and communicating funding with and other pandemic activities with members. And finally, to increase the visibility and capacity in order for funders to be able to influence other countries and other forums. And this platform and this kind of meetings are one of the ways in which we increase our capacity and communication ability. Next slide. So I will not go over this. This slide is basically to show you in the context of COVID in the last year, all the activities that GloPID-R has done. The WHO actions are shown in orange. The GloPID-R coordination activities are shown in green, and the dark green is the GloPID-R actions per se. And some of these include, putting together the research forum back in February with WHO that led to the global roadmap, and some of the other actions, including organizing synergy meetings in July, and now this meeting here in December. Next slide. So I'm just going to choose in the last minute that I have three types of activities that we have done in the context of COVID-19 to highlight. The first one, as I said before, was the development of the research priorities with WHO through the WHO GloPID-R roadmap and forum and roadmap that was held in February, and then the roadmap came out in early March. We've identified gaps in research and investments through tools and scientific meetings, including the UK CDR research project tracker that currently has more than 5,000 research projects and with funding to the tune of about $500 million from multiple countries that is listed on there. The synergy meetings that we have organized in July that were very successful and led to a good assessment of the remaining gaps. The long COVID meeting that we are doing today and yesterday that will hopefully identify some additional research gaps that will be hopefully the focus for funders over the next few months. And then the global coordination and partnership, including COVID Circle, which is focused on COVID-19 research and coordination and learning in low and middle income countries. We provide frequent updates from WHO, CEPI, and other funders. And finally, we participate in many activities like encouraging our members to sign data sharing in public health emergencies, an initiative that was led by Welcome and WHO, and that led to the signing of many research organizations on this. And I think that's pretty much my last slide. So I'm going to hand it back to you, Yazdan. Thank you.
Thanks a lot, Charu. Thanks a lot for your energy, for your leadership. And sorry, it's 6 o'clock in the morning in Toronto. Now it's my pleasure to introduce Peter Horby, who is the Executive Director of ISARIC, who has been extremely active during this pandemic through, of course, recovery. And thanks, Peter, also for co-organizing this meeting on long COVID. Peter.
Thanks very much, Yazdan. Yeah, and it's a pleasure to be here, and it's a pleasure to be co-hosting this meeting with GloPID-R, but also the long COVID support group. It's really nice to be so engaged with the patient groups, and we're really learning something from that. So I'll just introduce ISARIC, which is stands for the International Severe Acute Respiratory and Emerging Infections Consortium, which is a terrible mouthful, but which is why we call it ISARIC and we don't give it the full name. Next slide, please. So ISARIC is it's a federation, it's a grassroots federation, and I'm the current executive director, but it's had multiple chairs over the years. And it started in 2009 after the pandemic influenza outbreak, where we really felt amongst a group of clinical researchers, there really wasn't enough progress made in understanding the disease, progressing treatments, etc., for severe flu. So this federation has been built up over those years, and it's a federation of clinical research networks. And we have a very clear mandate, a clear vision, which is that we want to help prevent illnesses and deaths from infectious disease outbreaks, because really, science underpins improvements in both care of patients, but also in the public health understanding and public health control of epidemics. And so we have two things we want to achieve. One is to generate and disseminate the clinical research evidence needed to improve care and prevention. And the second is to build up this federation of clinical research networks. So working together as a federation to try and standardize what we're doing, work together, facilitate progress, and really work as a community to try and improve the response to emerging infections. Next slide, please. So we've now got 50 member networks. So a member is a network. It's a network of clinical research sites that are enrolling patients in studies. And so we have 50 members. It's not 50 people, it's 50 networks. And together they cover over 132 countries currently. So we have a very large global spread. And one of the ISARIC partners is in China and was involved in the Wuhan outbreak in the very early stages. So the very earliest clinical description of COVID-19 that was published in the Lancet was done by an ISARIC member with support from other ISARIC members and using ISARIC tools. And also the very first clinical trials were done by an ISARIC member with support from other ISARIC members, including our colleagues in Saudi Arabia who had already worked on MERS coronavirus and had protocols. So it really, I feel, worked very well in terms of a mutual support network to make sure that we can respond quickly. Next slide, please. So we're doing a lot of things, but just to highlight a couple of those. One is our clinical research tool. So we have developed what's called a case record form, which is like a questionnaire about clinical data on patients, which we had developed for respiratory infections. And so we were able to use that very early on in COVID. And it was used, as I say, in the very first month in January, and was used for the very first clinical description. And all our tools are freely available. They're there as a public resource to be used by anyone who wishes to. And so this slide is a little bit old, up until September, but by September we'd had 12,000 downloads of our research tools across the world, and they were being very widely used. And so those tools have been used to collect data on patients admitted to hospital with COVID-19. Next slide, please. And so what we've done is we've built up a very big clinical database of patients admitted to hospital with COVID-19. And this slide again was done in September, but now at that time we had 100,000 patient records, but that's really increased now. And we have now over 300,000 records of patients with COVID-19 from across the world. And we're increasingly getting more diversity across different countries. And this is proving to be a really great resource. We've published the data, we make it publicly available, and we've now got more than 10 different analyses going on, which are put to us by our members who say we want to look at renal dialysis or risk factors or obesity, etc. And they're able to access the data and really try and maximize the global benefit of this resource. Next slide, please. And so we realize now that that's very much focused on the acute patients. And as we're here to talk about long COVID, we do realize that there is this much longer term issue with COVID. Now the acute patient data can tell us something about who has risk to prolonged symptoms, but many patients with long COVID were not hospitalized, so there's a gap there. So we've been working with WHO on expanding the remit really. So we've been involved in the long COVID systematic review, which you've heard about yesterday. And also we've now developed a case record form for patients with longer term symptoms, so we can really try and contribute to what's happening about understanding and managing long COVID. But this is a small part of it. And so really, I think a bigger contribution is to work with the patient groups and with others in this forum to really try and drive forward the agenda of long COVID research to make sure that it's meaningful, it's scientifically robust, and it meets the needs of long COVID sufferers. Thank you very much, Yazdan.
Thank you, Peter, and thanks a lot for your presentation and for all you're doing. So, I'm coming from the HIV world. In the HIV world, about 10 or 15 years ago, we thought that we cannot do research without patients. And we did the same thing in Ebola, we did the same thing in Zika. And I think it's extremely important to involve patients. And the other thing during this epidemic, that many of us are ourselves patients. And I think this is probably something that has not been that often. I am myself patient, and many of us are ourselves patients. But that's not the reason. The reason is that we should hear the voice of a support group. And it is a real pleasure that this forum has been organized by the institutions, research institution, but also by the long COVID support group. And it's my pleasure to introduce Jake Sweat, who is a doctor in anesthetic and intensive care. He has worked hard to help and raise the issue of long COVID, including among people that avoided admission to hospital, and has collaborated with others living with the condition to achieve this. Jake is going to summarize the day one for us. Thanks a lot, Jake.
Hello, everybody, and welcome to day two. It's my pleasure and privilege to be able to introduce the second day for you. I'm hoping I'll be able to see my slides shortly. And I would like to begin really by thanking everybody involved in organising this event, GloPID-R and ISARIC, and all of my brothers and sisters from around the world who are living with long COVID, who have been so involved. Unfortunately, I can't see my slides at the moment, so I don't get a chance to do my Chris Whitty impression and ask for the next slide. I will go from my notes. But what I found most powerful yesterday was the contribution of the people from around the world. We heard from Basha in India, who talked about the stigma and talked about some of the problems in getting care, how she's had to spend so much of her money to try to get some access to medical care. We heard from Loazi in South Africa, who talked about his fears of reinfection and the difficulties of getting support there. We heard from Konstantina in Greece, who is just 28 years old and who had to move back in with her parents. And these are the stories that we've been hearing for months of relapsing and remitting symptoms, which are very debilitating and serious and scary. And this is exactly why people who are living with long COVID have been so convinced that they need to raise their voices. The themes that I drew out from yesterday were that people want this to be measured and defined and studied, but that there's actually a great deal of altruism in their desire for that. The thought that if we can prevent others from getting this too, that's so important. And that's one of the reasons why this needs such a lot of attention, because we heard from Hong Kong that many patients who'd received very high standard of care in the acute phase were not suffering from long COVID. So how can we prevent others from getting this with either acute treatment or better public health measures? But also that we don't forget those of us who have been living with this for 9 months. How can we begin to understand the mechanisms of what's going on in our bodies? because often we feel that our symptoms get better, we feel in our bodies that there's a chance, there's a hope here that this is reversible, whatever's going on. And it was excellent again to hear from Konstantina and a sentiment that was echoed by Professor Altman about the importance of not just studying and characterizing long COVID, but also beginning to think about the mechanisms and the treatments that people need to be able to live as well as they can with this disease. I also think it's really quite difficult, and it requires a lot of bravery and courage for people living with long COVID to share their stories in such a public forum with such a poorly understood disease, with so many people out there in the world denying that COVID even exists. So I would like to thank those people who shared their stories, and I know that they would have resonated with the millions of people around the world that we expect are living with long COVID. Some of the other gaps, we heard that a very small number of the research projects into long COVID, very low number of the research projects into COVID are looking at the long-term effects. And it's not clear how many of those look at patients that did not require hospitalization. So that's a big gap in the evidence base at the moment. And also it was quite striking to see that no projects at all are funded into looking at the long-term effects of COVID-19 in children. It was also a good insight from the Living Systematic Review that we need more robust studies, and that's where having such world-class experience and expertise from the scientists that are working with us is so important. And that's why I think this is such a shining beacon of good practice in collaborating with patient groups. So I think I will draw that to a close there, but to reiterate again, many thanks to everyone involved yesterday, especially the patients and especially the researchers and the clinicians who are so keen to use good scientific method to bring about positive change in the world. And that's really what good science is all about, and good medicine. I hope you have a fantastic day today, and we look forward to continuing this work together. Thank you.
Thanks a lot, Jake, and thanks a lot for your presentation. Thanks a lot for being there. And thanks a lot for all your input. So we are going now to move to the next session that will be chaired by Dr. Hanna Kinsey from MRC UK, that have been and has been active since the beginning of this epidemic, and then even before for the preparation. Thanks, Anna. The only thing that I have to ask you is that we're going to have a very short break of 30 seconds. So there's no time for anything. It's just 30 seconds to switch systems. So thanks and have an excellent day.
Hi, thank you, Yazdan, for handing over. Welcome to another session in which we're going to hear more about ongoing long COVID studies. So I'm really honoured to be co-chairing this session today at such a critically important meeting. I'm Hanna Kinsey. I'm a Programme Manager for Epidemic Preparedness at the Medical Research Council, which is part of UK Research and Innovation. And I'm joined today by my co-chair, Dr. Daniel Munblit. Daniel is an Associate Professor at the Department of Paediatrics and Infectious Diseases at Sechenov University, Moscow, and also an Honorary Senior Lecturer in the National Heart and Lung Institute at Imperial College London. And together we'll be introducing this session's speakers and putting your questions to them later in the panel discussion. So it's my pleasure to introduce our first speaker. This is from the Canadian COVID-19 Prospective Cohort Study, and it's a joint endeavour today with the presentation being given by Dr. Angela Chung and her colleague, Dr. Margaret Herridge, taking the lead in the Q&A. So thank you to you both for being here today, and over to you, Dr. Chung.
Great, thank you. Just want to thank the organizers for having us here today to talk about CANCOV. I'm presenting on behalf of my co-lead for CANCOV, Dr. Margaret Herridge, and also for all the investigators as well. Next slide. So the COVID-19 pandemic started in January in Canada. And currently there are 435,000 cases in Canada. And so in March, we started to look at sending in proposals to propose this study, CANCOV, across 4 provinces in Canada. It's British Columbia, Alberta, Ontario, and Quebec. And Ontario and Quebec are sort of the most affected provinces, with currently 135,000 cases in Ontario and 155,000 cases in Quebec. This project involves more than 100 investigators across Canada, including clinicians from different specialties, researchers, and scientists. And what we proposed was to do a longitudinal prospective cohort study with 1-year follow-up on 2,000 COVID-19 patients. 1,000 of those are non-hospitalized and 1,000 of those are hospitalized, split between those admitted to the wards and also to the intensive care unit. We also proposed to study 500 caregivers as well. That's because our previous studies in ARDS, acute respiratory distress syndrome, and in SARS shows that actually it's not just the patient who are affected, but actually their caregivers and families can be affected as well. Next slide. So the goal is really to set up a patient-centric platform where we can collect clinical data, research data, and biospecimens. And the objective is to look at the short and long-term outcomes of COVID-19, and also to look at the predictors of those outcomes. And those predictors include social demographic factors, genetic factors, both host as well as virus factors, and also the multi-omic, epigenomic, transcriptomics, and multi-omic kind of factors. We are looking at biomarkers as well, so cytokines, chemokines, and inflammatory markers, as well as coagulation and serological and immune function status as well. Next slide. What we are doing is we see patients and assess patients at baseline, 7 days, 1 month, 3 months, 6 months, and 12 months. And just like any pandemic kind of studies, it is a little bit messy. So some patients, when we got ethics approval and started, some patients were seeing the first visit, maybe 3-month visit or a 6-month visit. But there is a spread, and we're seeing more from baseline onwards right now. We are collecting social demographic data, comorbid illnesses, and medications, their primary daily activity, work status, symptoms, quality of life, mental health, stigma, resilience, complications from COVID, as well as we do a very detailed physical examination and functional testing, such as 6-minute walk test and at the MRC muscle testing, as well as we do pulmonary function test in those who have been in the ICU and other testing as well. And we also collect data on healthcare utilization as well as reintegration to normal living. Next slide. So I want to just give you an idea of where we are. So as of yesterday, we have more than 400 participants. And, you know, people talk about adaptive clinical trial. This is an adaptive observational study. When we first started, the eligibility criteria was that people have to have a positive COVID test by, usually it's by nasal swab, PCR. However, soon, starting probably in June or July, we start hearing about people having long-term symptoms, but no positive test. And so we started a cohort that do not have a positive test, and we're doing serological testing on those. So you can see in the chart that we have 165 of those with symptoms consistent with COVID. And those we are doing serological testing. We have 104 non-hospitalized patients that are tested positive, with 55 hospitalized but not in the ICU, and 66 who were hospitalized in the ICU. We have 12 caregivers right now. So it is an ongoing study, and I can share with you some preliminary sort of findings. Next slide, please. I think this group is really interested in the long COVID symptoms, and we are seeing a wide spectrum of those. It is a very heterogeneous disease. Some patients will really have 2 or 3 days of symptoms and they are back to normal, while others can be 9 months out and still have residual symptoms. And some of the common residual symptoms are shortness of breath, especially with exercise, tachycardia or racing heart, fatigue, and brain fog. And insomnia is also a very common complaint as well. I think what is a bit of a disconnect for patients and the healthcare providers is that often the physical examination is normal, the oxygen saturation is normal, the chest X-ray is normal, and the pulmonary function tests are normal. And so it is hard to sort of pin it down to saying, oh, this is the abnormality and we can fix it. We are doing more testing in terms of biomarkers and see if we can offer an understanding of the mechanisms and the underpinnings of why some patients have these symptoms and others do not. We are also offering a integrative medicine kind of approach to trying to help these people recover as well. One of the after seeing, I think, between Margaret and myself, we saw more than 160 patients so far. And for me, I have seen patients at multiple time points. And one common theme that I can share is that I believe that there's an autonomic dysregulation involved. And we will understand more. This is just the beginning in terms of the understanding of these long COVID symptoms. Next slide, please. So I just want to end with this slide and thank CIHR, or the Canadian Institutes of Health Research, and the Canadian COVID Immunity Task Force, the University of Toronto, and the Canadian Frailty Network for funding support. There is more detailed description of our group on cancov.net, and those are the ways that you can touch base with us as well. And with that, I thank you for your attention.
Thank you very much, Angela, for such a wonderful presentation and outlining preliminary results from CANCOV. And I would like to pass over to Dr. Joseph Breen. He is the Immunoregulation Section Chief of the National Institute of Allergy and Infectious Diseases at National Institutes of Health in the US. And hopefully he will provide us with some information. There was a recent workshop on post-acute sequelae of COVID-19 in the very beginning of December, which summarized some knowledge on post-acute manifestations of COVID. So Dr. Breen, the floor is yours.
Great. Thank you, Daniel, and thank you for to the organizers for giving me this opportunity to tell you a little bit about a workshop that was held actually less than a week ago, virtually, of course, where we invited a number of researchers, patient groups, patients themselves, as well as folks that are supported by NIH and other program managers like myself. The goal of this meeting was to summarize existing knowledge in really post-acute manifestations of COVID-19 and to identify knowledge gaps. So it was really designed to take in information to help us understand how we were going to address this, and really in some ways take what we've been bringing in terms of acute study of COVID-19 and how are we going to transition and make sure that we're able to look at long COVID sufferers with these post-acute manifestations. The meeting was really 3 parts. The first part was really a clinical presentation. Really, we had a small patient panel led by some ID physicians, and it was really a very strong and great way to start the meeting. And there's a lot of similarities to actually what I've been watching in this forum. Some of the take-home messages here were that the magnitude of this is really it really hits you very hard. Even if these long-term complications are rare in terms of numbers, the magnitude of the pandemic means that there's significant public health impact. And I think some of the stories that we heard from the post-COVID clinics in the US, and in fact, some of our international partners were really very powerful. And another theme was that we need multidisciplinary integrated care, very similar to what Angela just described. And that there was a lot of stigma. There was a lot of, the patient panel actually, they talked about how it's hard to be recognized, how many physicians they had to visit, for example. And people of color are experiencing a greater burden of disease and death, unfortunately. And that there was some hope that maybe a silver lining is that as we attack this problem, that would help us to eliminate some of the inequalities that it's showing in our healthcare system. And really, this was something that Peter Piot from UK actually said at the meeting and really resonated with everyone, that health equity is the road to ending COVID-19. Can you go to the next slide, please? So I'm going to go over just some of the research gaps. I can't do justice to all of, a 1.5-day meeting, but as I'll show in the end, that this is all publicly available as well. So I hope that if I don't get to it, that people will visit where you can get all this summary information. So in terms of data measurement and study design, we really need to know what are we dealing with here? And this was expressed by researchers, patients, funders, et cetera. What is the basic incidence, prevalence, natural history? We need to phenotype and have a common vocabulary to understand this. And importantly, we need controls or some sort of baseline assessment to really understand. And one thing that was talked about repeatedly was that electronic health records may not be complete, and we probably need prospective in-depth studies. Certainly for mechanistic data, that's the case. But at the same time, we need to leverage existing cohorts and trials and investments that we've already made. And hopefully we can pivot some of the studies of acute disease and then really add the tools and things that are needed to look at the long COVID sufferers. And of course, need data platforms to share this information. Can you go to the next slide, please? In terms of the science, the meeting had really three sections. One was the clinical part. The second was really a little bit of reporting out on some of the contemporary science that we know about acute and then also post-acute and long COVID symptomology. And and then there were 6 different breakout groups in areas such as neurology, pediatrics, cardiology, the groups that you might expect, where there was a 90-minute discussion, a very detailed discussion of what we know, what we don't know, what we really need to put our heads together and figure out to understand mechanistically so that we can come up with effective treatments and prevention, of course. So we need to continue, where the groups really, some of the conclusions where we need to continue to study the virus. We need to understand the receptor because it's not clear all the organs that are affected and how that correlates with the receptor expression that we do know of. We need to understand genetic factors. And another big point was we bring in lessons from other disease conditions, such as post-ICU conditions, influenza, which was already mentioned, and ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome. And we need to cover a full spectrum of COVID patients. We heard this from Jake earlier. We need asymptomatic, mild, and severe disease because it's not clear how well or if that correlates with long-term COVID. And we need to include patients with PCR and with and without PCR or antibody positivity. There were a lot of reports from patients, particularly early on when those tools weren't even available and they're clearly suffering from COVID and were not measured appropriately at that time. And we need to ensure inclusion, really referring back to the issues that I discussed earlier. The entire conference is archived and available at videocast.nih.gov. All of the conference was publicly broadcast, but is archived there. Next slide, please, and my last slide. What's next? So we're compiling the knowledge gaps identified in the workshop to make them publicly available. There was a group of organizers, would include multiple people from NIH that were involved in this meeting, and we're putting that together now. We'd like to continue working with our CDC, WHO colleagues, and other stakeholders, such as those here, to come to consensus on how to define a heterogeneous collection of sequelae involved here, and identify ways to facilitate collaboration and knowledge sharing between even the workshop participants, because it was a really important synergy between what we're hearing from patient advocacy groups and the physicians and mechanistic expertise of the biologists and immunologists, for example, that were present in the sessions. And I'll stop there. Thank you very much.
Thank you very much, Joseph. And thank you for outlining the latest evidence on long COVID. And I would like to head over to Frances Simpson. She's a lecturer in psychology and counseling at Coventry University. And she's also a sufferer of long COVID. And her kids suffer from long COVID as well. She's a founder member of Long COVID SOS group. And she also set up a wonderful long COVID kids support website and support group, kicking off a study. So Frances, the floor is yours. Thank you very much.
Hi there. Thank you, Daniel. Okay, yeah, I just wanted to talk today briefly about my experiences of children with long COVID, my children and the experiences of other parents, the long COVID kids study that we've started, and the need for further research. Next slide, please. So I'm speaking today, first and foremost, as a mother. My children are 6 and 9, and both caught COVID from me in March. My son was ill first. His was mild, but strange, bizarre set of symptoms, painful testicles, insomnia, a slight cough, painful eyes. This disappeared fairly quickly, but has come back in various forms since. His appetite comes and goes. He feels nauseous a lot of the time, He has a metallic taste in his mouth. His vision goes strange. He gets headaches. He's developed Alice in Wonderland syndrome, so quite often he will say that he sees heads shrinking. My daughter, who's 9, was more severely affected. She had 6 full weeks of being fatigued, pale, dizzy, nauseous, no appetite, aches and pains. Since then, we've had better days and worse days. Her appetite is still poor. She still feels sick quite frequently, has stomach pains. She also gets rashes that flare up. You know, we've also had some frightening experiences in which she's not been able to breathe properly, her throat closing up, her chest feeling tight. Next slide, please. Okay. Thank you. As a co-founder of Long COVID SOS, I spoke to the World Health Organization in August about my experience, but with only anecdotal data, there was a limit to the impact. I decided to do a scoping exercise and sent out a survey to support groups on social media. 162 parents responded, of which the overwhelming majority, 86.85%, stated their children had ongoing symptoms of over a 3-month period. The highest number by a small margin were in the primary age category, with 50% of children aged 6 to 11. This was followed by secondary school age category at 40%, and the rest were in the 0 to 5 age group. The details of their symptoms corresponded with the adult population. Fatigue was a symptom experienced by most children at 75%. Interestingly, 68% identified stomach pain and 61% confirmed that gastrointestinal issues had been experienced. Other symptoms of note included persistent fevers, nausea, mood changes, rashes, dizziness, breathing difficulties, and cognitive blunting. The option was given for them to provide written symptoms, and this led to an extensive list of unusual symptoms that capture the multi-systemic nature of the condition. In a further parallel to the adult experience, the majority at 74% described the illness as relapsing or remitting. Although the study was informal and had many limitations, it seemed interesting enough to justify further exploration. So at this point, I collaborated with Dr. Amali Loka-Kamagi to write the BMJ blog article, Counting Long COVID in Children. This was a call to arms for research into morbidity in the pediatric community. Next slide, please. I then became involved in the campaign group and support group called Long COVID Kids. With the help of parents, we made a video as a means to raise awareness. And within a month, there were 200 parents in the group, a number that goes up daily, all with similar stories of children with an array of diverse symptoms after infection with COVID. We approached a company called People With, who have an app which allows individuals to track and record their daily symptoms, both to provide data for doctors as well as for research purposes. This has led to the Long COVID Kids study, which is allowing us to capture the anonymized data of the group participants. This was only started recently, so the numbers are still fairly low at 48 children aged between 1 and 19, predominantly female, 34, males make up 13 and other 1. Over 80% are white. The 2 most common symptoms are fatigue and headache, followed by anxiety, brain fog, dizziness, chest tightness, joint pain, nausea, diarrhea, insomnia, rashes, sore throats. The average number of symptoms per user is 11.1. 203 unique symptoms have been added. Next slide, please. Having been involved in the starting up of the Long COVID Kids support group, I've been privy to the experiences of other parents. All parents share some common experiences: the fear that there's no recovery, learning to live with strange and unpleasant symptoms, the lack of knowledge about the virus, and the conviction by some medical practitioners that children don't experience this, and even that the parents might be slightly dubious. Even now, as we're making progress with raising awareness of long COVID amongst healthcare professionals, policymakers, and the public, there's still a real lack of awareness that this can apply to children. For a number of reasons, some of them personal and some political, there's a resistance to engage with this fact, but it is a very frightening prospect that a generation of children may be affected long-term by this disease. What parents want is practitioners to listen to the child and the parent with an open mind and understand that we are worried for our children. Next slide, please. Besides this, what parents really want is research into long COVID in children. Areas for research include the need to quantify morbidity in children and to investigate the pathogenesis. Is this the same as long COVID in adults? Is there a correlation with MISC, PIMS? For those of us who have lived through the nightmare of caring for chronically ill children without much medical support or knowledge, for our children and for the many who'll come after us, this situation needs urgent attention. Thank you. Thanks, Daniel. Thank you, Daniel. Passing over.
Thank you very much, Fran.
Oh, Anna, sorry.
No, sorry, that was me. Thank you very much for that presentation. It's hard to juggle work and home at the best of times, even more so when experiencing the symptoms yourself. And at the same time, you're campaigning to raise awareness of this really important issue. So thank you for sharing your experience with us this morning.
Thank you.
It's my pleasure now, hopefully, to introduce our next speaker, Dr. Alpha Keita. We're having some technical issues, so we're going to try his presentation, and if necessary, we'll move to the Q&A and interact with him via the chat if we're not able to hear him properly. So we're keeping fingers crossed and handing over to you now, Dr. Keita. Thank you.
Okay, I'm Alpha Keita, and I'm the Deputy Director of Centre de Recherche et de Formation en Infectiologie des Données. And I'm going to talk briefly about the ongoing and future projects on coronaviruses in our center. We focus on one project that summarizes our approach. And like other scientists, we are convinced that infectious diseases are strongly linked to ecology. For this reason, throughout clinical research, epidemiological surveillance, we develop research work that mainly affect human, animals, and environment. Our work is part of multidisciplinary research agenda based on One Health approach. Currently, we are interested in the study of prevalence, genetic diversity, and geographical distribution of coronaviruses in wild birds to assess the risk of future genetic transmission. Near this study, we work also on the study of dynamics of the coronavirus outbreak in general population in Guinea, which is a part of project to support the national response system with a large social science component. and also on clinical, virological, and anthropological evaluation of people cured of COVID-19 indeed. Now, I will give you some, next slide please. I will give you some data about this project. That with this project, we aim to provide the new insight on coronaviruses in population in African countries with high likelihood for reemergence of zoonotic infection from birth in order to evaluate the risk of additional outbreak and global spread with specific objectives such as development and or optimization of diagnostic tools. Next slide, please. It is a project funded by INSERM for 4 countries on basis of collaboration for several years. Now, sample and experience already present. Next slide, please. We conduct a pilot study in Guinea, and in this pilot study, we work on 319 birds from different ecological zones. We found 11% of birds carrying coronaviruses with wide diversity of alpha and beta coronaviruses, and the sequence in the same group of coronaviruses highly pathogenic for humans. It is important to note that 72% of the birds were captured close to human habitat. Next slide, please. It is a project with serious prospects that will make it possible to provide new information on the circulation of viruses responsible for zoonotic disease in wildlife and the degree of exposure of human and animals. Also can give information on the diversity of viral species, animal and human in the study area, and have a practical implication of the prevention, epidemic management, diagnosis, and treatment of zoonotic disease. Thank you all. Thank you for organizer. You gave me opportunity to talk about this project in our center.
Thank you very much, Alpha, for your presentation. And we should be moving now to Q&A session, probably. Okay. Hanna?
Hi, thank you. Sorry, I did not hear properly the end of that presentation, but thank you very much, Dr. Alpha. So yes, we're going to just take literally a couple of questions because we're very, very tight on time. I think we said we'd try and ask a question both on adults and on children. If I can dive in from looking at the chat, are there any plans, does anybody know of, to start a cohort in children and young adults who are affected by COVID? If anybody wants to tackle that one.
Daniel, do you want to answer that?
Well, probably both of us should be answering this question. So we're kicking off a cohort in Moscow. We got ethics approval, so we're kicking off in about a few days. So next week we'll be kicking off and aiming to follow up around 500 to 600 children to see how prevalent is COVID, long COVID in children. And also there are a few initiatives in the UK which are wonderful initiatives, and there were a few applications to UK-RA, and hopefully at least one of them will be supported. And Fran, right? What would you say? Would you say that one of the initiatives should be supported.
Yeah, hopefully. Yeah, there's like Daniel says, there's a few that have just been put in, so we should find out in January. But it does sound, yeah, I think at least one of them should be supported.
Yeah, hopefully.
Hopefully.
Thank you.
Thank you.
I should also say we're joined on the panel by Dr. Alex Can Blydenstein from the Long COVID Support Group in South Africa. And if I may, I would like to ask her to introduce herself briefly and just offer some very brief reflections on her experience and what we've just heard from our speakers, which will hopefully wrap up this session. Thank you. Is Alex there?
Yes, hi.
Good.
Hi. So, hi everybody. I'm Alex from Blydenstein, and yeah, so I am a pulmonologist and working in South Africa, and I was part of the COVID response team, the initial COVID response team when we first started, and then I was the first consultant who fell ill with COVID, and initially I was quite mild, and I stayed home. And when you self-isolate, I don't think you realize quite your symptoms, just felt like a flu. And it was only once I came back to work that my colleagues noticed that I was very dyspneic and, you know, not coping very well. I just thought I was deconditioned and, you know, wearing a mask again. So I was forced into being tested. And I experienced quite severe dyspneas, tachycardias, desaturations with wearing a mask and with exercise, occasional chest pain, and I had right heart strain on exertion, with a profound fatigue, brain fog, and I still get quite severe nominal aphasia at times. So that was in June. I am currently doing my PhD in COVID and looking at the endothelium. And so the whole situation has been quite sadly ironic for me. And I'm pretty sure I had quite significant endothelial inflammation from the markers that I tested and the subsequent tests that I've done. And thank God it's been 4 months and now I've stopped desaturating. I still get quite profoundly dyspneic and tachycardic with exercise, but I've been allowed back to work. My 6-minute walk test is okay again, although one can manipulate that quite easily. And I think in two parts, the long COVID for me has been really two components. The one component has been the endothelial kind of dysfunction that I think I had, which is slowly coming right. And the other component has been an emotional component where I felt very guilty initially because I was letting the team down at the time of the surge. And now, again, now that I'm feeling better and it's been almost 6 months and I worry about my antibody status and feeling guilty that we're going to be getting our second surge now, and guilty that I'm going to take it home to my family again, and worried and feeling guilty that I'm not quite on top form. I still run the ICU at COVID where I work. And yeah, I just don't feel exactly like I used to, but I am functional. And yeah, so it's been an interesting ride. I am very grateful for being allowed this opportunity. And I'm very grateful and share a new perspective with patients now. And that has been a good learning point for me out of this episode for me.
Thank you very much, Alex. So I'm really mindful of the time now, unfortunately, that we need to draw this session to a close. So I think we've heard some really interesting presentations and discussion. And while it's really difficult to summarise those in a few seconds, it's clear how important it is to explore long COVID in different cohorts beyond those who were initially hospitalised by their acute symptoms. And I think also, given that this is a new disease, we've got an opportunity to really do things right from the outset by ensuring patient involvement informs and shapes our research questions and priorities, and to go on this journey together. So I'd like to thank all of our speakers, and we'll now go into a final, which is
Hello from Switzerland. My name is Chantal. I'm 52 years old. I used to run marathons. I was very fit healthy. I have absolutely no underlying diseases.
Hi, my name's Kate. I live with my husband and our 4 and 7-year-olds. We've all had long COVID for 8 months since we first got it in March.
I got sick with what I believe was COVID at the beginning of March. My main problems were shortness of breath, chest pain, sometimes burning, sometimes tightness of chest, heart palpitations. I just can't get my pulse and heart rate down.
I am 41. I was fit and healthy. I didn't think this was going to be a big problem for me. But even in the first couple of weeks, I was really ill. I called an ambulance a few times, but I didn't get admitted to hospital. The early symptoms were really worrying, particularly gasping for breath and chest pain, but also things like shaking and passing blood.
I got eventually diagnosed with reduced lung function and perimyocarditis in the summer. Incidentally, that was exactly the same diagnosis my daughter also received. She's 17 years old. She collapsed during football training. She used to be very fit as well.
I've had over 60 different symptoms and it's been really, really frustrating. I'm pleased that my children are improving a bit. They're back at school, but they still don't run around like they used to, and they still have some strange problems. My husband's also still unwell and really struggles with fatigue and breathlessness and aches and pains. I've realised 2 things. Recovery is not going to be straightforward. I've already caught a cold a couple of times and had to test again and isolate again twice. And getting a cold gives me COVID-like symptoms again. That's really worrying for the future. And I've also realised that even though long COVID is being recognised now, it's still really hard to get the right kind of medical help. I'm being referred to all sorts of different departments, and when things come back clear on test results, some doctors are still suggesting that this is anxiety and stress. I looked really ill for the first 3 months, but now I look more normal, and that affects how your friends, your family, your employer, strangers, and even doctors treat you. And it reminds me very much of my mum who had MS. And back in the old days, sometimes people were labelled with hysteria until they figured out a way to diagnose multiple sclerosis.
What we would like to see from research is guidance on diagnostics and management of long COVID, just to prove that we are not all completely crazy. It would be good that there are some diagnostic tools, some tests that physicians could use to diagnose the disease. There could also be some tests on lung performance, on heart performance, on exercise capacity that could help to diagnose it. Until we have reliable tests, we probably need to define a set of symptoms that would define what long COVID actually means, because I don't think we will have that reliable test anytime soon. All in all, we need a multidisciplinary approach with regard to diagnosis, management support, and eventually treatment and prevention of long COVID, because I don't think anybody wants to go through this again. I thank you very much for your work. It's very important what you're doing, and we all appreciate it, all the long COVID people in Switzerland. Thank you very much.
I know that research is coming. I know that there'll be more information and maybe some drugs in the future to help. But what I'd love right now is for doctors to believe me, take me seriously, and think about ways that we might try to manage my symptoms to make me more comfortable in the meantime. And that does make me feel positive about the future.
Hello everyone, and following on from what was quite a moving testimony there from Dr. Alex in South Africa and how long COVID has impacted on her day-to-day life and indeed her career as a doctor. In this first half of the next session, we will focus in on mental health related issues and central nervous system. Unfortunately, Dr. Hanna from the World Health Organization is running slightly late, and we hope he will be able to join. And so I'd like to introduce Professor Simon Hatcher from the University of Ottawa, who's a consultant psychiatrist, and we really look forward to hearing what he has to share with us. Thank you very much, and over to you, Dr. Hatcher.
Thanks very much. Good morning, everybody. Well, actually, it is morning here. I'm not quite sure what time it is around the rest of the world, but thank you so much for joining us and for inviting me to present here. So my background is I'm a psychiatrist. I'm a frontline healthcare worker. I work in the homeless population in Ottawa, and I work in liaison psychiatry. And what I'm going to tell you about is a study we haven't done yet, but we're just about to start, which is the Eastern Ontario COVID-19 Community Mental Health Cohort Study. Next slide, please. So as I'm the first speaker, I can set the background. Every man and a dog is writing reviews about the mental health consequences of COVID-19. One of the earliest and best reviews, systematic review, was in the Lancet earlier on in the epidemic. And they reviewed the mental health consequences of SARS, MERS, and COVID-19. And as in all these reviews, there's they conclude with a prevalence of mental health disorders, which in this case, about a third of people after contracting those disorders got PTSD, about 1 in 7, 1 in 6 got depression, and about the same proportion with anxiety. However, not unexpectedly, most studies which have looked at the mental health consequences of these infectious diseases are small. They're self-selected samples. Most of the information around have you got a mental disorder or not, what are the consequences of being infected by these viruses, has relied on self-report questionnaires, which you all know overestimate the prevalence of disorders. Only one study looked at cognitive function. None of them looked at substance use, and few of them had any comparison groups. So we aim to try and address those criticisms of the existing literature. Next slide, please. So in our study, we have 3 aims. The first is to determine the mental health outcomes, whatever that means, and it's the boundaries around what is a mental health outcome contract and expand depending on who you talk to. At 1 year of people who have tested positive and negative for COVID-19 in Eastern Ontario. The second aim is to determine the clinical, social, and demographic predictors of these mental health outcomes. The third aim is to determine the mental health outcomes for healthcare workers at 1 year who have tested positive and negative for COVID-19 in Eastern Ontario. We only have funding for a year, but the intention is to extend this study for a much longer term follow-up. Next study, please. Next slide, please. So, how are we going to assemble these cohorts? Well, I work at the Ottawa Hospital and the Ottawa Hospital Research Institute, which is a large tertiary care hospital in Ottawa. In fact, it's one of the largest hospitals in North America. And we're fortunate that some bright spark at the Ottawa Hospital started a COVID-19 registry at the beginning of the epidemic. So everybody who's had a test for COVID-19 in Eastern Ontario that goes through the Ottawa Hospital is on this database, which is one of the big barriers to doing these sorts of studies is how do you actually identify people. We're recruiting people over 18 years and over who've been tested for COVID-19 and who have agreed to be contacted for research, which again is anybody who does research these days knows that research ethics boards frown on people being contacted out of the blue for this. We are specifically looking at people who haven't been hospitalized. The reasons for that is, there's two reasons for that. One is because there are already studies being done on people who've been hospitalized, especially in ICU. I mean, I'm involved in that study here, but also that getting controls for people who are hospitalized is actually quite difficult. It's actually much easier to get controls if you haven't been hospitalized. We're going to age and sex match the two cohorts. We're going to have 2 controls per case, and we're aiming to get 200 cases and 400 controls. The cases are people who tested positive. The controls are people who tested negative. Next slide, please. And these are the assessments we're doing. Nothing particularly surprising there. The usual range of mental health outcomes. We're going to be looking at substance use, psychosis, because there is an association with psychosis and flu infections. A small number, but a significant number. It's recognized. It was certainly recognized both in the Russian and the Spanish flu epidemics. We're going to be looking at fatigue, cognition. My experience is that's the big thing which is often missed out, is looking at cognition. We're going to be looking at sleep and well-being in terms of outcomes. And we're going to look at these assessments at 6 and 9 and 12 months. And as I said before, with certainly the intention of rolling this out for a longer period of follow-up. And the predictors, the confounders, and the effect modifiers we're going to be looking at are usual demographic factors. Well, actually not the usual demographic, we actually quite a number of demographic factors we're looking at. Past medical and mental health history, how the initial infection affected people. Again, because if you look at the history of flu epidemics, one of the things that people noted at the time was that the brain complications following infections with flu didn't seem to correlate with the respiratory infections. So we're testing that out. We're looking at adverse childhood events because that's again something which is often missed out. But when you work in liaison psychiatry, you work in that interface between mental and physical health, that's clearly a significant factor. We're going to be looking at current mental health treatment, and we're going to be looking at social support. So I'm sorry, I don't have any results, but that is what we are planning to do. And if part of the purpose of this conference is to just describe the landscape of current research, that's what we're doing for mental health outcomes of COVID-19 in Ontario, Eastern Ontario. So that's my presentation.
Thank you very much, Dr. Hatcher. Really interesting and very important points to consider. I'm now delighted to welcome our chair for this session, Dr. Hanna, from the World Health Organization in Geneva, Switzerland. And he's a technical officer there at the Department of Mental Health and Substance Abuse. So over to you, Dr. Hanna, to introduce Dr. Netravathi. Thank you.
Gail, thank you very much, and I'm going to hand over to Dr. Netravathi from the National Institute of Mental Health and Neuroscience. Dr. Netravathi, floor is yours, please.
Thank you. At the foremost, thank the organizers. This is a very good forum where we're going to discuss on the mental health and how this is affected in the long COVID. Next slide, please. So we all know how intelligent we have become as to how this COVID, next slide, please. How COVID has affected us in the last 1 year almost. So initially we thought this is just a flu-like illness, respiratory problem, pneumonia, but now we know there are multiple extrapulmonary manifestations affecting the brain, heart, blood vessels. So for a large pandemic as this, you can just imagine where the health resources are geared up to combat this pandemic. It is but natural that the mental health is the one which is being taken a back seat. But we should remember that this is the one which is going to have long-lasting consequences. Next slide, please. So if we see, initially when the research papers came out in the initial pandemic, it was all on non-COVID patients, on general population, healthcare personnel, as well as people who already had a neuropsychiatric disturbances as to how they are understanding, how they are coping up with the pandemic. There were reports of people Especially in India and Pakistan, there were reports where people, because of lockdown, were not able to get alcohol, and there was behavioral changes, withdrawal symptoms. People who were stigmatized because of getting COVID infection, and they had feared that they're going to transmit this to their family members, attempted suicide. So there were a lot of depression, fear, anxiety, which gripped most of the population. Next slide, please. So one of the way is, whenever we have a pandemic, we try to go back to see how the previous pandemic has affected the mental health. And this was 2 major studies which try to see how the pandemic previous ones in the 18th and the 19th century affected the patients and what we can learn from them. So there are a lot of clinical features which I've listed upon, but what I would want to stress upon is that nearly more than 2/3 of them did not go back to work even within 2 to 3 years. That is huge. So a person who had just a flu-like illness still was not able to go back to work. And you can imagine in COVID, we have nearly around 3 to 30% of them who are having neurological manifestations. So does it mean that the mental health is going to be severely affected or not? That time is going to tell. Next slide, please. So if we see the few studies which have been done in COVID-19, very few case reports, case series, mainly addressing that patients had difficulty in sleeping, night startle response, insomnia, depression, anxiety, suicidal ideation. And sometimes the OCD features which were there had increased. So these were the many psychiatric symptoms which were addressed. Most commonly was the fatigue, mental fog in nearly 50 to 60% of them. And this was followed by 20-30% of them having anxiety, depression, and then fear. Next slide, please. So this was one of the small study which we did at our institute. Ours is mainly a neuropsychiatric hospital. So in our neurological emergency, we just try to see how many of them who have come with only the new onset neurological disturbances, how many had COVID positive, and it was nearly 15% of them. And you can see there were no COVID symptoms in nearly 60% of them. And the most common neurological disturbances in them, it was stroke and GB syndrome. And when we try to assess the psychosocial features among the cases and controls, it was mainly the anxiety, depression, and stigma, which was higher in COVID positive patients than COVID negative patients. And when we followed them up, the stigma continued to be high. Next slide, please. So if we see how the psychiatric consequences are going to affect, it is multifactorial. Next slide. So basically, brain infection. We know that COVID affects CNS and causes brain infections. And in the previous Spanish flu, there were encephalitis lethargica like picture where patients develop Parkinsonism, hypersomnolence. So we need to have a long study of these people who have survived COVID and see whether they're going to develop any further complications. And then the disability because of stroke, cognitive aspect because of hypoxia. Next slide, please. And after they have survived the COVID-19, they are coming to a society where they are facing difficulty in going back to their family members, healthcare. Sometimes there is an economic crisis, lockdown, unable to get food, stigma, unable to be accepted in a family or even in their workplace. So this is the way, multiple ways the COVID pandemic has affected. Next slide, please. So next slide. Next slide, please. So what we have to learn is that very little research is done, but we should remember that this is the one which is going to have a long-lasting effect. And it is important for us to have a comparative study between those with other acute medical conditions as well as those with respiratory and neurological complications and have a correlation with cytokines. Thank you. Next slide, please. Thank you.
Thank you so much, Dr. Netravati. This is a brilliant overview on the mental and neurological aspects of COVID-19. Really excellent presentation. May may I request? Yes, perfect. I see my slides now. Thank you. Can we move to the next slide, please? Colleagues, as we all know, COVID has exposed the troubling situation of community-based mental health services globally. These services, even before COVID-19, were like this person we see here in this slide, carrying a very heavy burden directly uphill. Now COVID-19 has entered the picture with significant, considerable direct and indirect impacts on mental health globally. COVID-19 itself comes with many mental and neurological manifestations. It also comes with stigma that exert considerable cost in itself. The problem is not only the direct costs of or the direct effects of COVID-19, it's also the pandemic itself, causing widespread anxiety, panic, and feeling of helplessness, hopelessness, and uncertainty in many communities across several age groups and vulnerable groups. COVID is likely to exacerbate also symptoms of pre-existing mental and neurological disorders and increase the deaths and severity of illness, as well as long-term complication of COVID-19 among this group specifically. Next, please. In a WHO survey conducted between June and August this year, we found that 93% of the countries responding, 130 countries responded to this survey. We found that 93% of these countries are saying that mental, neurological, and substance use services are disrupted. Services for the most vulnerable group has been the worst affected. Almost 3/4 of services for children and adolescents, mental health at school services, workplace mental health services has been reported by the countries as disrupted. Almost 60% of psychotherapy and counseling services has been disrupted, as well as harm reduction services has been disrupted in 50% among the countries responding. Next, please. WHO has prioritized mental health in the COVID-19 response as a cross-cutting issue, relevant for a wide range of pillars, including risk communication, clinical aspects, continuation of essential health services, and that has been reflected in numerous WHO and UN documents, including a UN policy brief from the UN Secretary General. Next, please. WHO has also responded with a wide range of resources, for example, on risk communication for the public on coping with stressors related to COVID-19, from a self-help guide to a children's storybook available in more than 100 languages, to a platform for caregivers of people with dementia on how to cope with COVID-19 and its stressors. Next, please. The clinical aspects of COVID-19 has been also addressed by WHO in a dedicated chapter in the clinical management of COVID-19, dealing with the mental and neurological manifestations. We have also documented best practices and published on a dedicated platform in Mental Health Innovation Network. We also included mental health guidance for continuation of essential health services. Next, please. And mental health is also relevant for organizations' operational aspects. So we provided guidance for agencies and first-line responders through, for example, a guide on how to integrate basic psychosocial skills into day-to-day response for all essential workers to COVID-19. Next, please. Thank you. And emerging evidence suggests that there is an elevated risk of acquiring COVID-19 and experiencing worse outcome, especially among people with substance use disorder. Unfortunately, what's obvious and worrisome is that this service has been significantly disrupted. And not only substance use services, but also there is a link we are seeing more and more reported in literature between COVID-19 and behavioral addiction, such as online gambling and gaming. Next, please. And when considering COVID-19 and neurological disorders, there are three vital issues that are emerging. First, the increased risk of severe illness and mortality from COVID-19 for people with pre-existing neurological conditions. Second, neurological manifestations of COVID-19 in the acute stage. Third, what we're discussing today is the long-term neurological outcomes across the life course. There are reports of long-term neurological complications of COVID-19, even in people who have had mild illness. The complications include headache, fatigue, concentration difficulties, and potential increase in risk of cognitive impairment and dementia. Next, please. Colleagues, the long-term impact of COVID-19 is a topic of increasing importance and discussion, but our understanding of this topic is still developing. WHO is continuously monitoring the literature, talking with clinical networks and engaging with our WHO collaborating centers and other actors to understand these long-term manifestations and identify appropriate and effective strategies to address them. So far, we have seen associations with depression, with substance use, with post-traumatic stress reactions, which are commonly reported, in addition to the experience of cognitive impairment, fatigue reported, as well as the neurological sequelae. Social stigma also remain a concern in the long term. Next, please. Recovering from COVID in long term will depend on bold efforts to strengthen health system, ensure up social protection, protect economic opportunities, and bolster multilateral collaboration and enhance social cohesion. The UN has very recently published a framework for priorities in research, where mental health has been integrated as a cross-cutting issue in different subjects, including the long-term impact on COVID-19, not only directly on the patients, but also in general on the community. Thank you.
Thank you, Dr. Hanna. So if you could now take 2 questions from your panel. Thank you.
Thank you very much.
Hello, shall I start with a question? I was wondering, thank you very much for your presentation, firstly, it's excellent presentations. How can we distinguish between neuropsychiatric and psychiatric consequences of COVID-19? And do you think, would it be important to involve immunologists and neurologists in any studies looking at mental health effects, for example?
Jack, thank you very much for this excellent question. And I'd like to invite my colleague, Dr. Netravati, to take this question, please.
Thank you. Mostly what we have to remember is the neuropsychiatric aspects usually comes with some neurological deficits, or there will be some memory impairment or limb weakness or behavioral changes, which will be, we have, as a neurologist, what I have seen is that there are few conditions which we can differentiate between neuropsychiatric and psychiatric complications, as well as we do a neurological assessment, which will give us an idea as to what it is. But overall, whether it is neuropsychiatric or psychiatric, what you have to remember is it is important to control it in the initial part. And your next question about immunological, yes, there are few studies, especially in the psychiatric component, that the psychosis is supposed to be increased whenever there are few interleukins and cytokines which are increased. So it will be good, worthwhile, especially to see whether patients who have developed a cytokine syndrome, whether those people are prone to develop any of the neuropsychiatric complications. I agree with you that we should be involving. So it should be a multiple disciplinary approach, neurologist, psychiatrist, psychologist, as well as a social psychologist. They should be involved. Thank you.
Netravati, I think COVID reminds us of the importance of working through a multidisciplinary approach that not only include neurologists and psychiatrists, but remind us to work with other colleagues from different disciplines, including those who work also in rehabilitation and post-care. Jack, may I invite you to ask us another question, please? From
Can I actually respond to that question as well?
Please, Professor Hatcher, thank you.
So my first response is I actually don't know what the difference is between neuropsychiatric and psychiatric symptoms are. And I don't know why it's an important question, but I think what it's getting at is the problem which has bedeviled all the research into chronic fatigue syndrome, is you get people dividing into these 2 very distinct camps of it's all psychological or it's all physical, but we don't know what it is. And I think that's what it's getting at. This is a way to avoid that whole mind-body split, which always happens when you're dealing with the brain, and you're dealing with symptoms which are sometimes hard to explain. And clearly, it's multidisciplinary research. Research is a team sport, and you need different disciplines involved. in the study we're doing, we have infectious diseases physicians involved. We don't actually have any immunologists involved, not yet. I could certainly see how that would happen in the future when we start looking at both the why and the how symptoms happen. So I think what the question is getting at is, how do we avoid that split? So I'm not entirely sure the answer to that, but I think that's what it's getting at. You tell me, Jake.
Well, I think you're right. It's a very complicated area, isn't it? And I think people have gone through, I mean, I'll put my hands up. I really thought I was going to die in March. And so I completely put my hands up and say that this has caused me some serious, what I would call psychological distress in its own right. But the other concerns that I hear from other people is that, loss of sense of smell perhaps indicates some degree of neuroinvasiveness. I know that many people have felt as though sometimes they gasp for breath and they have these strange dysautonomic symptoms. So I suppose the reason why people feel it may be relevant, particularly as a patient, is because if it gets categorized as, oh, you have these symptoms because you're anxious, it's less likely to lead to research which might help those people. But I agree, it's a completely complicated and very complex area, but it's just very good to have it out there and discussed in that framework. So yeah, thank you.
I mean, we're dealing with the brain, and nobody knows how the brain works. So
yeah,
we just need to keep an open mind and clearly involving patients is really important in the research here. And in our research, we have 2 or 3 patients who've had COVID involved in our research team.
Brilliant. Thank you, everybody.
I just reflect on the very relevant remark by Professor Hatcher when at WHO we were developing the mental and neurological chapter as part of the clinical management. There were ongoing discussion. Shall we make a split between the mental health aspect and neurological aspects in management of clinical COVID? And after long discussions, we decided not to make the split because indeed there is an overlap. But it's important to keep in mind, because I'm reading also a number of other questions here, that the depression and anxiety linked to COVID-19 is like depression and anxiety also linked to in other situations, including associated with non-communicable disease or other infectious disease. It's biopsychosocial, so it's multifactorial, and it's you cannot really associate it with in a cause effect in a way.
Thank you.
Okay, good morning. So now we are going to continue with 3 more speakers talking about what is going on in long-term COVID-19. First, I would like to introduce myself. My name is Felipe Reyes. I'm a critical care physician and the head of the infectious disease department at the Universidad de la Sabana in Bogotá, Colombia, South America. So first, I'm going to start talking about some of the projects that we have here in Colombia and then we are going to move to three outstanding speakers that we have today. So first, I want to talk about what is COVID-19 in Colombia. Next, please. So far, we start seeing cases early in May. Then we got a peak around by the beginning of August. And since then, we have been in a plateau of around 7,000 cases a day. So far, we have almost 1.5 million cases in Colombia, with 40,000 people died due to COVID-19. It's important to highlight that Colombia is only a 40 million country. Next, please. So systemic complication of lower respiratory tract infection have been known for many years. And now that we start seeing COVID-19, we start believing that those complications also happen during COVID-19 and after the acute episode. Next, please. So cardiovascular complications are present in around 30% of the patients with lower respiratory tract infection. However, this incidence and prevalence is unknown in patients with COVID-19. Next. It's important to highlight that those complications could be arrhythmias, heart failure, myocardial infarctions, and strokes. And the patients that develop those complications are those that are most likely to die. A very important point to highlight here is that the most important risk period are the first 30 days after the lung respiratory infection, but that risk could remain up to 10 years afterwards. And the only pathogen that have been related with this is Streptococcus pneumoniae. Next, please. Also, in the influenza infection has been also related with cardiovascular complications, and this paper published in New England Journal of Medicine highlight this. Next, please. Next. And then this is just a figure to summarize what are the mechanisms of these cardiac complications. So the pathogens can directly invade the heart, cause necroptosis into the heart, and then long-term sequela by cardiac scarring. So what we're doing now with COVID-19 patients is, next please, is that this is our clinic. We have around 500 patients with COVID-19, 100 patients with other community-acquired pneumonia etiology. And then in the Universidad de la Sabana, we are trying to dissect the mechanisms associated with long-term cardiac complications of COVID-19. Next. And next, please. And then this is just the outline of our study. We are collecting samples during the hospital admission, and then follow up the patients for 2 years and collecting samples and making echocardiograms and all the kind of assessment that you can see in the figure. Next. And then what is unknown about this thing is the prevalence is unknown. What is the impact of long-term mortality and disability of cardiac complications? Which are the mechanisms associated with this? And what should be the medication that we use to treat these patients and prevent cardiac complications? Next. With that, I finish my presentation, and I would like to pass over to Dr. Sally Singh. She works at the Laser Hospital. She's the head of the cardiac and pulmonary rehab unit. Her research focuses on pulmonary rehabilitation and digital interventions to support rehabilitation and recovery. Professor Sally has been working with national clinician leaders to build a groundbreaking platform that is called Your COVID Recovery. And we are very pleased to have you, Dr. Sally.
Thank you very much for the introduction, and that's exactly right. I'm going to talk a little bit about recovery and share with you all the digital platform that we've been developing. So next slide, please. This data is taken from both hospitalized patients and patients that have had community managed COVID infections. And what was interesting was that reporting of symptoms was not dramatically different between those that had been hospitalized and those that hadn't. And this was over a large group of patients and extended over 80 days. And you can see, if you look on the left-hand side, that at follow-up at around 80 days, the most common symptoms reported were fatigue, breathlessness, chest tightness, cough, muscle pain, and headache. So next slide, please. We don't really have a definition at the moment of what recovery might be for patients post-COVID. But based on my experience with pulmonary rehab in particular, I've taken that definition that may need altering, but really the fundamental aim is to improve an individual's exercise capacity, functional ability, promote behaviour change and well-being. Now, I'm not entirely sure that's suitable for patients that are post-COVID. Pulmonary rehab may not be the ideal forum either, but we can certainly look at that in a moment. But I think the aims of the post-COVID recovery are really to support a full recovery for a significant proportion of people. Many may not have pre-existing long-term conditions, to support symptom management, and importantly, compared to traditional cardiac and pulmonary rehabilitation programs, really support a return to full economic productivity. Many of you may have seen this article in the BMJ that's particularly focused on community managed COVID, and it is a complex algorithm, but what I'd like to highlight on the bottom left-hand side is that many patients should be referred to pulmonary rehabilitation. So next slide, please. So this data is taken exclusively from hospitalized patients, but based on the previous graph, you'll understand that actually the symptoms aren't terribly different. And I've just tried to overlay what pulmonary rehabilitation and combined with cardiac rehabilitation may obviously address and be an ideal vehicle to support recovery for these patients. Because of course, referring back to earlier talks, this is of course a multidisciplinary intervention that we know reduces breathlessness, fatigue, anxiety, and depression. So we can see that there would be strong evidence for pulmonary rehabilitation being able to reduce fatigue, breathlessness, cough, sputum retention, and perhaps less convincing evidence around joint pain, chest pain, lack of appetite. But actually, I suspect that's because the evidence hasn't been accumulated necessarily, but a multidisciplinary program should address all of these issues. I think where we would struggle to claim any impact would be around the autonomic nervous system changes that we see around loss of smell and taste. So next slide, please. So we recognised in the UK, or England in particular, that there would be a huge demand for recovery support, and recognised that it would be almost impossible to deliver this face-to-face for obvious infection control and volume reasons. And so we developed a website called Your COVID Recovery that has two phases. The slide you can see at the moment is the public-facing site that contains a lot of accessible information around what's happened to you and actually trying to support your recovery. And this was developed with a very broad range of healthcare professionals with expertise, but importantly, patients who had had experience of COVID so that it was accessible to them and their family. Next slide, please. The second stage of the platform is for people that are particularly struggling to recover from their symptoms. And this is a package that would mirror, if you like, the components of a cardiac or a pulmonary rehabilitation program, but have been embellished in a rather large way. So it's an interactive rehabilitation platform that healthcare professionals can monitor, but it's not required that there's heavy monitoring and following up of patients. In the graphic on the right-hand side, you can see who's been involved. So we've had contributions from cardiologists, respiratory physicians, psychologists, people who have expertise in smell retraining, returning to work, and the list goes on. So next slide, please. So the patients enter the site and are asked to complete the EQ5D as an outcome measure, and also the COPD assessment test, which we looked at as an overarching measure of symptoms in patients with COVID, and published that a couple of months ago in Thorax. And this is just a couple of screenshots of what the site looks like. Patients set their goals, and then from that, they would be entered into various modules that address their particular issues. If you look at the picture on the right-hand side, we just have here fear and anxiety, and it's populated by videos, interactive quizzes, diaries, etc., etc. So next slide, please. What I've tried to show you on this slide is the number of components of the site to give you this feel that it really is a very overarching site that covers many of the, if not all of the top symptoms that patients are reporting. So we have breathlessness, cough, fatigue, fear and anxiety, getting moving again, managing your day, pain, memory and thinking, concentration, sleep, etc., etc. So hopefully that gives you a real feel that this just isn't either cardiac or pulmonary rehab, but is really a very comprehensive package for patients to follow post-COVID. And can I have the final slide, please? So I think there's clearly a lot of work that can be done in the rehabilitation space and around the COVID population. I don't think we really have a true understanding of the prevalence of the symptoms, particularly in community managed COVID. We don't really have any firm data on what the demand for a supported recovery or rehab program might be, and what that program might look like. And then, of course, how effective it is, irrespective of whether it might be a face-to-face or a digital program. Thank you.
Thank you so much, Professor, for such a great presentation and the work that you are doing. So now we are going to move with our next speaker. Is going to be Dr. Kenneth Bale from the University of Edinburgh at the United Kingdom. Dr. Bale is a critical care physician and a senior researcher that leads the genomic study, which is a study of patients admitted to the ICU, where they're trying to identify the genetic characteristics of these patients and determine if these may have an impact on clinical outcomes. So thank you so much, Dr. Bell, and the floor is yours.
Well, thank you very much indeed. It's a privilege to speak. I'll tell you about the work we've done to prepare for outbreaks of new diseases. Of course, the newest disease that we're tackling is long COVID, and our most recent experience has, of course, been with acute COVID. But we were trying to prepare for this across the ISARIC consortium, as many on the call will know, for a decade since the influenza pandemic. Next slide, please. So I'm going to tell you about how we prepared and what we thought would happen, and then what happened and what I think we've learned. So we designed a system with a global consensus behind it, put together over many years with a group of investigators from different backgrounds from across the whole world, in which we'd have 3 different tiers of activity, and we'd be able to stratify activity according to local resource requirements. So that means both limitations in resources in some regions of a country where it's not possible to gather samples, for example, or across a whole nation where research infrastructure isn't as strong as it is in other places. Next slide, please. So we designed this modular approach in which the tiers build on top of each other, and the foundation of everything is, of course, just gathering clinical data and no biological samples. We anticipated that it would be shaped something like a pyramid, with the largest number of cases in the lower tiers. And of course, that stratifies not just according to resource, but also the data requirement. So you don't need detailed RNA-seq data from every single patient in the country who has the disease, but it is often useful to have some clinical data from literally every case. Next slide. So we anticipated that these studies would fit together in an adaptable way in different settings, both within and across different nations. Next slide, please. This is how we planned it to work. So of all patients, we hoped that we might get to something like 90% of cases in an imaginary future outbreak. This was our prediction, in whom we would get clinical data, case report form, CRF, to enable us to understand the characteristics of the disease. And we would build on top of that a single sample and then serial sampling to really understand disease biology. And as my slides have shown, the intention is to build clinical trials on top of that foundation. So the whole objective here is that combining studies, doing as many studies as possible in the same patient, creates additional opportunities for discoveries by combining information across those studies. And instead of building a clinical trial randomly across the population, we want to build it where the sampling is already happening. Now, in reality, the COVID outbreak is on a scale that has been far beyond what any of us have experienced before. And so the reality is that when we've operationalized this, we haven't managed to have complete overlap, as you would predict, between these different categories of sampling. Next slide. So in the UK, we initiated this study many years ago, and we operationalized it this year in COVID. And we've recruited 117,000, the slide's slightly out of date, patients into the study now who've contributed clinical data. And from those patients, we've obtained 3,500 biological samples that are now distributed across the UK, as shown in this map, with all of the data pouring into a data analysis hub on a single computer, which actually combines data from multiple different studies and from NHS clinical records from the healthcare system in the UK, to enable us to facilitate access by external researchers to make additional discoveries about COVID. So I'm just going to tell you a few of the things that have worked well in that study and the findings that we've found so far. Next slide. So very early, the findings were all from the clinical data, because of course that comes in fastest, and we were able to report very granular clinical data across a very large number of patients, making observations, for example, about the pattern and age distribution of cases in the UK and critical care resource usage. Next slide. The impact of age on personal risk was already known at this point from very rapid studies that were conducted using the same protocol in China at the beginning of the outbreak. And using this additional data, we were able to identify the effect of obesity, for example. Next slide. Looking at biological samples in the same patients with granular clinical data and other biological samples from the same patients has enabled us to look for patterns of immune activation and stratification within the groups of patients that have been exposed to COVID. And this work by Ryan Thwaites and Peter Openshaw exemplifies that and is available on medRxiv. If you search for their names, you will find it. But I won't go into the details of that, but it does show what the potential is of gathering data from the same patients. And finally, next slide, please. Looking across the genome for genetic variants associated with disease. Now, this is acute COVID, not long COVID right now, but of course we intend to do the same for long COVID. This offers the opportunity to identify causal biology, so we can find genes that actually cause different disease outcomes. And in this case, what we've done is compared critically ill patients from a study called Genomic, which is a global collaboration to study the genetics of susceptibility to critical care. It's open for any investigator to join, and there's a core team here that will provide infrastructure support to any group who want to contribute by leading their own local study and having facilitation in whatever way is helpful from our team. And we've discovered 5 strongly associated genetic variants that determine an individual's risk of acute COVID, which are shown on this plot on the slide. Next slide, please. And we've shown that these replicate. So the same pattern is detectable when we combine the data from other studies that have occurred using mostly hospitalized patients, not critically ill patients, across the world. And what really excites us about this is that this leads to multiple new therapeutic targets. So the genetics leads us directly to genes that we can already target with drugs and generates hypotheses for testing in clinical trials and drug repurposing. Next slide. These two websites contain the acknowledgements. There are far too many for me to read out just now, but I mentioned some of the investigators who've contributed along the way. The ISARIC 4C study, led by me, Callum Semple, and Peter Openshaw, has lots of information at the website, and the genomic study, which is a collaboration of currently 1,400 people, is open to new collaborations and to providing help to any investigators who want it. Thanks very much indeed.
Thank you so much, Professor Bale, for such a great job, and congratulations. So now we are going to move to our last speaker, is Dr. Ryan Sarakansky from the University of Manitoba in Canada. His research focused on the hematologic aspects of critically ill, where he leads several national and international randomized control trials in the field of sepsis and transfusional medicine. So go ahead, Dr. Ryan, and thank you so much for being here.
Thank you very much. Yeah, pleasure to be here. I'm a critical care physician and hematologist. I work in the center of Canada in a province called Manitoba, but I guess we all work with each other easily now in COVID. Next slide, please. I'm going to talk about anticoagulation related to COVID. These are disclosures that are they're grants related to COVID trials that relate to anticoagulation specifically. Next slide, please. Okay, so thrombosis appears to be pretty prominent in COVID. There's been the concept of the endotheliopathy, endotheliitis. Definitely there is endothelial activation in many patients causing thrombotic complications. I mean, this is my day yesterday, just yesterday. You know, the 52-year-old male with no past medical history came in with a cerebral vein thrombosis, COVID positive, and Cont in the emergency room, an uncle herniation, and a 28-year-old patient with COVID on the ward who was doing better, who just up and died, and I presume it was a pulmonary embolus. And yesterday I put someone on ECMO who had a pulmonary embolus, and we usually use VV ECMO, but this is a VA ECMO situation. There's a lot of thrombosis going on in our center right now. Up to 30% of patients will develop thrombosis, and those who are critically ill have high incidence of thrombotic.
Good to see everybody.
Hi. Maybe someone can mute the other people on the panel, please. Next slide, please. These are a couple of observational studies from France and the Netherlands, where 17 to 20% of patients in the hospital developed thrombotic complications that were venous. Next slide. But it's not just venous complications. Arterial events such as stroke and cardiac injury have been reported, as well as thrombosis in usual sites. Next slide. Perhaps D-dimer. This is a reflection of clot breakdown. Once clot occurs, it's broken down into individual molecules. Once it's cross-linked, and D-dimer may be a target to identify people at risk. Certainly people die more if they're high D-dimers, if their D-dimer is high. Perhaps it's a way to stratify people for which care may be directed. Next slide. Currently, we're not sure how to impact care by D-dimer, by the way. Lots of people are making it up, and there's a lot of individual observational-based data or observational-based practices, the eminence-based practices going on based on D-dimer. We really don't know if we can impact care by D-dimer at the moment. And so, like, how do we prevent thrombosis from occurring? How do we treat it? What drugs do we use? For how long do we use these drugs, and what dose, and whom, et cetera, are important questions. Next slide. Can you press the but one more time, yes. And so I lead a trial with a couple others. It's called a multi-platform RCT. Perhaps it's a word we made up, but the multi-platform RCT speaks to several things. One, a global collaboration to solve this issue. It is essentially one RCT that is being conducted in 5 continents around the globe, organized by 3 main networks. One is called the ATTACK network that I lead. One is called the REMAP COVID network out of Australia, and I chair the anticoagulation domain of that. And another one is the NIH-sponsored Active4 platform. And all 3 of us run one trial of therapeutic anticoagulation versus usual care in COVID. It's a very novel trial design. It's Bayesian, it's adaptive, multi-platform. All the data go to one center for interim efficacy. Actually, we're waiting to hear about it right now to see if we reach a trial conclusion or not in severe or moderate or high or low D-dimer. So we're understanding a lot of things about anticoagulation at the same time, and we plan to all stop the trial once a conclusion is met. It's a really innovative design, I think, that will set the tone for COVID trials. Next slide. And so there are a lot of research priorities in COVID-19 for sure. And just with respect to thrombosis, there appears to be an increased thrombotic tendency, but we're not totally sure. The early observational studies were in the ICU. They were early in the pandemic when we didn't have steroids or other immunomodulatory agents at our disposal. Now we all use dexamethasone or some other equivalent. Some use remdesivir, others using tocilizumab, and emerging data suggesting it's effective. So really unbiased large observational study is needed, and that is the Virtuoso study that Deborah Siegel has started in North America. The therapeutic question versus usual care. Well, I'm trying to answer that with my colleagues under the multi-platform trial, but it's not the only trial out there. In fact, there are like dozens and dozens of anticoagulation trials. They're mostly all going to fail because we haven't collaborated well globally. But I think the multi-platform trial is an example of what I think it would take to solve this question quickly. Who's at high risk? Well, we're not totally sure. D-dimer is a hypothesis, but that's an important research question. Like obesity was mentioned in the last presentation. Maybe it's obese patients, maybe it's those with previous risk factors, maybe it's those with other inflammatory markers. What is the role of antiplatelets? REMAP and Active4 studying this, but maybe Solidarity will pick up an antiplatelet arm now that really there's no great agents being studied in the trial. What about a NOAC? Well, it has less appeal to low and middle income countries, but a Freedom trial in South America and Spain is evaluating this. And what are the long-term consequences? Outpatients, pre-hospitalization or post-discharge, should we have some degree of pharmacologic prophylaxis long-term or extended? Next slide. And so, what's the important outcomes? Is it thrombosis? Is it death? How is the rate of thrombosis interacted by inflammatory agents? Not sure. What trial designs should we use? Probably adaptive, innovative ones. And the final slide. We will have to come together to make this question. This is really important, but most trials are small and will fail. A global collaborative environment is really required to solve this question in the short term and in the long term. Thank you very much. I'm happy to answer questions.
Thank you so much, Professor. And you're right. The only way to solve this problem is through collaboration. With that, we finish this session, and then and now we're going to go to a short break before we can move on. Thank you so much.
Hi, my name is Robin Dunlop. I'm 35 years old, and I'm from Johannesburg, South Africa.
Hi everyone, my name is Marie Oakler and I live in the northeast of Brazil.
Hi, my name is Liliana and I am from Mexico. I am 48 and I got COVID on April the 2nd.
My husband and I contracted COVID at the end of July, and both suffered symptoms ranging from high temperatures, body aches, fevers, diarrhea, vomiting, and loss of taste and smell. After about 10 days, my husband began to feel better, but I took a turn for the worse. I became extremely weak, and what followed was a week from hell. I was throwing up and could not get out of bed and could not open my eyes due to light sensitivity, and I had terrible headaches. Once I was able to open my eyes, I noticed I had complete double vision, along with vertigo, and the headaches continued.
I've been suffering from long COVID for 6 months now. I've had a total of 58 symptoms. All the symptoms in the green chart have more or less gone now, sort of ending at month 5.
I have been suffering of costochondritis, that is an inflammation on the thorax, bulging veins, headaches, migraine, bradycardia, high heart rate, and brain fog, and I don't know what's the cause of those symptoms.
I was referred to a neurologist who conducted an emergency lumbar puncture and found that I had elevated intracranial pressure, which was causing double vision and headaches. I was placed on medicine to correct the elevated intracranial pressure, which I'm still on today. I was also diagnosed with post-viral fatigue syndrome. What followed was 37 days in bed, where I could hardly walk and barely ate, all the while still experiencing complete double vision, painful headaches, and fatigue I cannot explain. I had to take a month off work to recover, and after that took another 2 months of working half days.
Now I'm into the 6th month. I'm still getting all the symptoms on the blue chart, which are mostly neurological. Brain issues, brain fog, memory loss, vision issues, reading small text, letters mixing up on the page when you read and write. I've actually had quite a bit of difficulty recording this video and had to redo it several times. I've also been diagnosed with nerve problems. Up until 5 weeks ago, I'd say that one of the most debilitating symptoms was the ongoing fatigue. A fatigue like nothing you could ever describe to anyone. I've never experienced anything like it. Feels constantly like you've been hit by a truck, just taking a shower or washing the dishes, and then I'd be back in bed. But after being diagnosed with muscle damage from COVID, I undertook cardiorespiratory physiotherapy. And after a month-long course of rehabilitation, the fatigue is much better. That it was combined with some supplements prescribed by my specialist to boost the immune system. So there is light at the end of the tunnel for the people that are experiencing that fatigue. It's a slow road, like I've got some ways to go, but I can do many more things now than I could 5 weeks ago. 5 weeks ago, I wouldn't be recording this video for you.
It took a total of 9 weeks for my vision to return to normal and my headaches to disappear. What remains is debilitating fatigue. It has been over 4 months since I caught COVID, and I'm nowhere near to the person I used to be. Although I see improvements and I am very grateful for them, this is not what I want for my life. I went from an active and healthy 35-year-old with no known comorbidities to a shadow of my former self. Every day I wake up hopeful that today will be the day I feel like the old Robin.
I would like that the researchers investigate what is really happening to our body and our immune system. Why are some people very affected about that and others don't? We have been struggling with these symptoms for 8 months and we don't have any answers yet.
So I'd really like research in this area to see if these neurological and nerve issues can be improved or go away, or are they going to be permanent? I'd also like further research into the GI side of things, because I was one of the people that had extreme GI symptoms in the first weeks and months. And now I've seen recent research coming out that some people tested positive in the gut that had had GI issues during COVID. So that's $1 million question for me. Is COVID still active in my system?
Good afternoon, good morning, or good evening, everyone. Thank you for joining us for session 8. This session is the panel discussion on knowledge gaps and methodology. So my name is Dr. Janet Diaz. I was on a little bit yesterday morning, and just to introduce myself before I hand it over to my co-chair, I work for the World Health Organization, so I'm at the WHO. I'm in the emergency program, and I'm the lead for the clinical management response to COVID-19, but also work in case clinical management for other emerging infectious diseases. So it is my great privilege to be here for this final session of an important forum. So with that, I'm going to hand off to Piero Oliaro, who's our co-chair, who will start us off on this session. So thank you.
Thank you, Janet. Hi again, everyone. Welcome back. My name is Piero Oliaro. I'm Professor of Poverty-Related Infectious Diseases at the University of Oxford, and I'm also the Director of Science of ISARIC. So, right, we are here, we are faced with the daunting challenge tasked to try to summarize a range of incredibly valuable contributions, which essentially point to the multi-systemic nature of long COVID, and so would require multidisciplinary approaches. And to do that, we have here 6 people, 6 panelists representing patients. They've been selected for their expertise, and also because they represent patients, researchers, and funders. So I'm sort of in a rapid fire mode. So these people will be Margaret O'Hara, Gina Staff, Janet Scott, Fernando Bosa, Yazdanpanah, and Jean-Marie Abarugiral. Without further ado, I'm asking Margaret O'Hara to, everybody will have a very few minutes, like 3 minutes each, to try and identify knowledge gaps that have emerged, what sort of methodologies are more appropriate to address them, and therefore start help informing what the research's end might be. So Margaret has already spoken before, so Margaret, up to you. Over to you.
Thanks, Piero. I want to thank everybody for all the presentations. There's an amazing amount of research that's going on out there. And Professor Hatcher said that research is a team sport. And I think that's a really great phrase. And we can see that you are all working together. The professional researchers are all working together. You all have very slick protocols that Kenny Bailey described. You're all ready to go, and you work across the world. And we as patients have been forming those networks as well, and we have very well developed international networks amongst ourselves. And I think it's the matching up. Now, I would like to see the matching up now of that body of knowledge from professional researchers and the body of knowledge from patients. Because there are things which we would highlight to you that are perhaps missing out of the research. The ones that come to mind are community cases. There's not so much work on that, and children. And Francis Simpson gave a really, really moving talk about the effects on kids. And I think what I would say to professional researchers is just to ask yourself, what are you missing? If you're based in a hospital, to understand that you're getting part of the view, and to go and seek out what it is that you're missing, and to start from that assumption that you're not seeing everything. And what you're missing will be patient perspective. So it's seek out some community, seek out some people to contradict you, and to pick apart your study and tell you what's wrong with it. And I suppose part of that is relationship building, because we don't want to be criticized, and researchers love their research. We know we can tell how passionate you are about your research, and we know how hard you work. And it's not that we want to criticize you just for the fun of it. It's not that. It's that we want to be constructive partners in what you're doing and say to you, well, that's great, but actually, have you thought of this? And do you know what? You're missing out a kind of chunk of people that we know about. And so I think it's about building up those relationships, and that's what we would encourage you to do. I hope we've given you a flavour of the number of patient groups that there are out there. They're all across the world. There is nobody working anywhere who wouldn't be able to find a group of people who would be happy to talk to them. And we cover the gamut of all the hundreds and hundreds of different symptoms. We've seen how multisystemic this illness seems to be, and that requires multidisciplinary. We keep hearing multidisciplinary, which is fantastic because that is absolutely what we need. We really do need all sorts of different types of doctors and researchers and other allied health professionals, but also different types of patients. And our groups, our international networks, are the repository where you will find those people who will be happy to talk to you.
Thank you very much, Margaret. And this is particularly important coming from a person who's not only important as a patient, but also has been active for several years in patient advocacy and patient-led research for several years. So the next one to talk is Janet Scott. Janet has not spoken yet at this webinar. Let me just briefly introduce Janet. She's a clinical lecturer in infectious diseases at the MRC University of Glasgow Centre of Viral Research. She's a PhD. She's worked in amongst other things in West Africa, in Ebola, and she's worked also on post-Ebola syndrome. So she is extremely well qualified to talk to us about post-COVID. Janet.
Okay, so thanks very much. Good morning, good afternoon, good evening. I think it's been a great couple of days, quite inspiring, and I'd like to thank the organisers both for the meeting and for asking me to speak today. We've been hearing about recognition, rehabilitation and research. And as a researcher, I've found listening to the patients' stories both moving and quite informative. And I'd like just to highlight some of the research gaps as I see them coming out of this. We certainly need to characterise and understand the mechanisms of long COVID so that we can develop the treatments for the likely 5 million people who are likely to be already living with it. And there are some clear gaps. There are some populations that have been underrepresented in the current studies. As Margaret Hara has already said, there are those who were never hospitalised, who are more difficult to reach from a research perspective sometimes, and there are the children. But also I suspect the care home residents who aren't actually represented here, who are not necessarily on social media and sometimes don't have a voice, but were certainly had the rough end of the epidemic. Additionally, most of the studies that have been funded for 3 to 6 monthly follow-up visits, and they may miss the very fast relapsing, remitting nature of long COVID that sufferers have been telling us about. And next, from my background, maybe in post-Ebola syndrome, I'd just like to put a word in for comparative studies. It was really good to hear about the post-chikungunya work that was done, and it may be useful to compare some of the chronic problems following other viruses, also dengue and Ebola, and a plea, please not to forget the people living with the consequences of previous epidemics as the research funding and the attention moves on to the current one. And then finally, beyond characterising long COVID, I've been really inspired by actually something that Margaret said in the introduction yesterday and has been touched on by other speakers. That is that long COVID could be the pandemic of 2021. We need to stop creating long COVID sufferers, i.e. to prevent acute COVID going long. And to that end, I'd like to suggest maybe investing in the development of antiviral drugs that could be used in the community without a prescription at the very first suspicion of COVID-19, just like you might use acyclovir cream on the very, very first tingle of a little cold sore. We could start quite simply by testing the impact on long COVID on ongoing and future clinical trials of the current drugs that are in trial. However, I suspect what we're going to need here is a new drug. We're going to need our acyclovir so that people, hospitalized or not, can do more than to survive, but can do something for themselves and to survive well without long COVID in the first place. Thank you.
Thank you, Janet, for those words. We're going to keep moving on through the panel. At this time, we want to invite Dr. Gina Asaf to speak. She collaborates on the creation and distribution of the Body Politic newsletter, and they seek to provide healthy allies, medical professionals, and other interested parties with information on the support group. Gina, over to you.
Thank you. I'm not a doctor, but you know,
it came up as doctor on my paper.
Yeah, it's all right. I think it's the mess up with the swap card open or something like that. But thank you for the introduction. I'm Gina Asaf, and I'm part of the COVID-19 patient-led research team, and I'm from the Body Politics Support Group. We were the first to produce research on long COVID with a focus on non-hospitalized patients. We recognized early on there was a lack of awareness and understanding from public health research and the medical community and understanding what we are now calling long COVID. Outcomes of infection were looked at as binary back then, death or full recovery after 3 weeks. You know, we collected data on patients from our support group and others online who had symptoms and ailments weeks to months after the initial infection. I was one of those people. Many found our patient-led research valuable. This highlighted the importance of patient-led research. We focused on areas that were being neglected initially in the media and medical studies, such as neurological symptoms, non-hospitalized patients, and those people that had COVID symptoms but could not get tested early on because of lack of testing. The CDC, NIH, and NHS all have referenced our research. Ed Yong wrote about our research in The Atlantic in one of the first media pieces on long COVID. MECFS patient advocate groups reached out to us after reading our research and helped us understand the complexities and disabling effects of post-viral syndromes in some patients and the need for more research. Also, in several months, several academic and medical researchers are now collaborating with us under more formal processes. And so as a patient who has led research on COVID, I have some gaps in my mind of what's happening in the current research. And a lot of them have been mentioned during this forum, but I'm going to summarize them as this is one of the last panels. And, coming from a patient research, I kind of wanted to list them here. So one is we need to include patients who don't have positive tests in studies. Availability of PCR was low, especially in the beginning, and timing of tests is critical. We know the limitation of serological and antibody testing. We need to find either better ways to confirm COVID or include patients and disaggregate them in the studies for those that don't have positive tests. We need to acknowledge long COVID, but understand the complexity of the different systems in our bodies affected by this virus and the variability of symptoms. Not all COVID long haulers will experience the same symptoms and can be clumped together. We're likely not going to be treated all the same. But then on the other hand, some of us are presenting similar to MECFS. So we need to look into studies that also look into MECFS, which has been under-researched and other post-viral illnesses. We need to focus on non-hospitalized patients in studies. Anecdotally, my doctor at the post-COVID clinic in DC was telling me she's not seeing ICU patients or hospitalized patients 7 to 8 months later coming to the post-COVID clinic, but the majority of the patients are the ones with mild onset of COVID. Also, in our more recent survey, 90% of the 4,000 respondents were not hospitalized and experiencing major symptoms for more than 6 months. Many long COVID patients are not going to, show or may not show abnormalities with the typical medical diagnostic tests and are experiencing relapses. So symptoms may not be present all the time. So we need to listen to patients and look at their symptoms until we can figure out better diagnostic tests. We need to study and learn how long COVID impacts people's lives, types of works they do, look at different socioeconomic status and disadvantaged communities. How will long COVID impact lives differently? And then what is the true prevalence and incidence of long COVID? This has not yet been studied. And of course, this was mentioned a lot in the forum. What is the vaccine impact on us? So, I'm going to highlight what methodologies and tools that I think are important to address these gaps that also have been mentioned We need to fund patient-led, ensure patients are leading and helping us in defining what to look for and prioritize that type of research. Leverage participatory research methods. We need research that is actionable, timely, and communicated to medical staff and patients to make use of. And then we need to respect the patient's energy and think about collecting data in a responsible way, ensuring privacy of health data, thinking about, about data ownership differently, and not allow data scraping from social media. And in terms of funding, we should also partner with support groups where patients have been seeking out help online. We'll probably continue to do so. We need to fund the support groups. I want to close with the fact that I got sick in March and I continue to struggle with fluctuating symptoms, even up to today, 9 months out. There are many of us all over the world, as we heard during this forum, and it gives me hope and comfort to hear the voices of many other patients during this forum and promise of better research and treatments. Again, thanks for including me and other patients in this forum.
Thank you, Gina, for those words. We will go on now to Fernando Bosa from Brazil. Oh, Fernando, you're on mute. Oh.
Hi.
That's good.
Oh, thank you. Oh, then as a researcher point of view, this next years are an incredible challenge to answer all these questions that we learned in these last 2 days. And especially how to integrate all the information that have been generated during the pandemic, but also the new information that will come in this next years. By looking from point of view of a researcher in a middle-income country, I believe that one major challenge is how to have a view on the most vulnerable population affected by COVID-19 that we in general not include in the trials or even in the studies. Also, how to have focus on patients, families, and health professionals affected by the pandemic. From a more mechanistic point of view, much of our knowledge is related to acute disease and mechanism of acute disease. We not invested in the last years so much in how to understand the repair, resolution, and recovery of the disease. Also, much of our clinical trials are related to new drugs, but we have very few trials looking best practices, how the best practices affect outcomes and how the best practice can work as a prevention. Also, all the burden of neurocognitive and mental health relate to the pandemic, not only the infection, but also the economic impact and the social impact of pandemic in these different populations. Finally, the potential of new technologies, especially the digital technologies, need to be explored, especially related to a mechanism of recovery, how to integrate evidence-based information in these new technologies to provide assets for large populations, especially these most vulnerable populations. Thank you.
Thank you, Fernando, for sharing your wise words. And now we're going to move on to Jean-Marie Abarugira.
Yes, thank you. I'll just try to use the short time I have to outline a few things that came out in these 2 days. First of all, I come from a funding agency, so I'll speak from the perspective of a funder, funding clinical research, and mainly as our focus is Europe and Africa, as you'll hear from me. So we do fund those groups that are from Europe and Africa, basically respond to the needs of those populations that are neglected. So the first thing which came to mind is we need to make sure COVID-19 and long COVID does not become another poverty-related disease. I'm saying this because, of course, this forum is being attended by thousands of people. Thousands more will watch it on YouTube, whether live or not live. But there are some other populations that are in remote areas. I'm thinking about rural areas that are not even being covered by the testing capacity coverage that we are observing. So I'm thinking about that also based on a comment I heard earlier about someone who said that this should be long COVID. This forum should be an opportunity to think about how we can close some of those inequalities gaps. Some of us maybe are experiencing this for the first time, where when you are thinking about funding strategies to cover research gaps, you listen to the patient first. Normally we do have these stakeholders meetings talking to only experts, scientists, researchers, but this I realize, at least for me, is the first time I'm listening to the patients first before putting down a draft of research questions or research gaps. So that is one point to note, very important. Now, looking at what the funders should be doing, the knowledge gaps, the research gaps that we should be focusing on, there is this idea that the clinical manifestation of long COVID is really wide. Maybe it is from asymptomatic to very severe cases that we are still struggling to understand. And maybe I should mention that in the context that I'm looking at, the comorbidity should be given a place. So the places where you have HIV and TB and are going to be dealing with long COVID patients, we should make sure the clinicians are well equipped to deal with those cases of multiple infections on a long term. We should think of questions about treatment protocols. Janet Scott mentioned, I think, discovery and development of drugs that can be maybe over the counter, where someone think about having long COVID can just go to the next door to get a drug, which is not necessarily involving prescriptions, just to treat him or herself in a matter of hours, not waiting days, not making appointments. And this would be very important for resource and limited countries where normally access to healthcare is an issue, and we cannot build those health systems over a few months or over a year. So really developing some of these easy to get medical treatments would be important if we speak about long COVID. And of course, the prevention of long COVID is together with the prevention of COVID-19 itself. But for long COVID, I think that's a very important case, the discovery and development of drugs that are easily accessible and cheap. Of course, trying to close that gap, that wide gap between poor and rich. And then another point that I thought is worth mentioning is the social science element. Funders, of course, look at medical problems based on medicine, but when social science can help solve issues related to stigma, issues related to culture not ready to seek care, of course, someone will think, if you've had, for example, malaria or TB or have HIV, I'm not sure if long COVID will be the first thing which will make you go to the GP. So if social science can be embedded in the research that will be funding going forward, that will be very important to make sure people are not just isolating themselves at home, thinking that it's a continuation of another existing problem. And in a wider context, think about the capacities of institutions or nations or regions to respond to long COVID issues. I think we, the funding agencies, will have to find smart ways of capitalizing on earlier investments. So we all, whether any funder has some kind of projects where you invest, think about long-term, think about the capacity to respond to future issues. So we'll have to make sure covering these new research questions, we use existing networks. If supporting consortia working on Ebola in West Africa, for instance, we'll have to use those networks to make sure if there's a cohort that has been an Ebola cohort, if it can help us understand or address questions around COVID, that will be fantastic in terms of saving costs, but also tackling a new bigger problem which will be there for a long time. I think I'll stop there and hopefully maybe I can add more through questions. Thank you.
Thank you, Jean-Marie. And our final panelist to talk will be Professor Yazdan. So if I may introduce you as one of the coordinators of INSERM, reacting a network under the umbrella of AVSAN, Research and Action Targeting Emergent Infectious Diseases, which the goal is to optimize and coordinate the existing research capacities during emerging and re-emerging infectious threats. So over to you, Yazdan.
Thank you, Jeanette. So, you know, I'm always a kind of strange when I'm presented as a funder, but probably that is it. But I want to say also that I am a physician and I am for the first time a patient too. So emphasize on that. So the other thing is that when we come at the end of the panel to talk about gaps, of course, everyone has been said. So I'm not going to be very original, but just to go over, I think that I completely agree that first, we should be very careful about the population. And I really think that's one thing that comes from this meeting is the importance of children. The other thing, I think that we should be very careful about vulnerable populations. From what I heard, and specifically on the mental health, I think that we should emphasize research on these populations, and it was said. The second thing is the setting. I think many of, and even today, many of the studies were talking about patient who has been hospitalized. I think we should be very, very careful, very, very careful. And it has been said by some of the persons, Margaret, for example, in the beginning, emphasized on that. We should be very, very careful about including community and non-hospitalized patients. I think it's key. Third, I think the physiopathology, we don't know it. It's really, I think before going to treatment, we should understand what is the physiopathology. Before going to natural history, we should really understand that. And I think this is key for the future. And I think for that, there was a session on chikungunya yesterday. I think the parallels with the other infectious diseases and post-infection symptoms, it's extremely important. We should really emphasize on that. The other thing is I think that we should be very careful about the setting. I think that it could be something that could be also based on different settings because the stigma is not the same in different settings, because the natural history of the disease could not be the same in different settings. So I think we should be extremely careful. Jean-Marie touched base on that. And I think this is key also, although we should work together. And also one other thing that I want to say, but I thought it was going to be original, but Jean-Marie just said it before me, was social sciences. I think this is key. The social science at the whole on the societal impacts, stigma, and economic impact. Many people in my country have presented COVID just something with a pressure on the health system. We are saying here that it's even in young people, there is an impact. And I think there is health impact and there is an economic impact. And I think we should show this, and it's extremely important. And I wanted to finish with something actually that Peter brought up in the beginning. We should be very careful in homogenizing the methods of data collection to try to be able to work together. This is key for the future. And for that, we should talk together and even more talk together. We should talk together researchers and we should talk together funders. So I will stop there and thanks again.
Thank you, Yazdan. Thank you very much, and thanks to all the panelists here. Unfortunately, this session will be shorter than we thought at the beginning, we had planned at the beginning. But of course, there've been multiple comments that have been just coming throughout the entire webinar. and it's very difficult to summarize them now. But I think, like I said at the beginning, I think that many of them also reflected this multi-systemic nature of this condition, and the fact that, as Yazdan said, we don't really know, and many said we don't really know what's going on here, and therefore the need to understand the etiology of this. And one of the things that I mean, there have been many striking comments and statements made, particularly by patients. But one was that people want to know what's going on. And this is where I believe the biomedical and the more social science patient-centered approaches would converge. So maybe without asking anyone in particular, but how do you think that this could be combined? Because typically these are unfortunately seen as different disciplines. How can we put them together also through your experience, and maybe adding an additional layer of complexity, because the whole thing is going on against the background of health systems, and health systems that are being stressed as well, are being stressed by the pandemic. So anyone wants to try and address this?
Can I, Piero, can I just say one word? I think that, as you said, this should be multidisciplinary. I think multidisciplinary with patients and with researchers. And I think that this is something that we achieved very well in HIV. We really managed to have a multidisciplinary research with everyone around the table. And that's one of the reasons we were so successful, although not enough successful. And I think that we should really, within the start, don't do it within disciplines. It should be transdisciplinary.
Yeah, could I just say, thank you, Yazdan, for that. And I think it's fair to say that without patient involvement in HIV research, there wouldn't be, there's no cure for HIV as we know, but there's an effective cure in that people live for a long time, so it becomes a chronic illness and not a deadly illness. And I think patient involvement there was absolutely key, and that's what started the patient involvement in research movement, actually. And I would point people towards the NIHR in the UK, where we have standards for involvement, and these have been developed over more than a decade, co-created with members of the public. And they are very good standards. They're broad enough that they can be adapted for different settings. And I would encourage people to look at that. And I would highlight something that Gina said about resourcing. Something that's very important in the NIHR standards is the idea of resourcing patient involvement in research. So it's not just an expectation that we will or even can do it all for nothing, and that all of the research funding gets funneled into the researchers, into the institutions, and that there's nothing left over for patient groups. And that's something for the funders really to look at, that the NIHR is a funder, and the NIHR does not accept research applications where there is no resourcing for the patient involvement. You know, you actually are penalized for not resourcing it. And I think that's something for other funders to look at.
Can I maybe ask Gina for a final word about that, and then we wrap up?
Thank you. And, you know, this is something that, you know, our team, patient-led research, has, you know, we've been leading on research, of course, with help of different expertise. And, you know, and, you know, one of the things I noted in my talk was the energies of patients, and, you know, it can't be expected to, you know, come out of nowhere. You know, people with post-COVID or long COVID are experiencing extreme fatigue and other ailments that, you know, we need to be respectful of that. So in addition to helping them being involved and leading through funding, you know, thinking smartly about how we do this research in a way that is respectful of that energy, but also helping them lead on the questions that we are, you know, we think they need to be prioritized. and communicated to medical staff and to other patients. I mean, I guess my last point on that was, I talked about the support groups as well. So there's a lot of support groups, I think to sustain these support groups where research is stemming out of, I think funding them will also be, something I recommend as well. Thank you.
Thanks, Gina, and thanks to all the panelists. I think we're getting ready to wrap up this session, and I just wanted to highlight a few things that come to my mind before we hand it over to the end of the session. I want to focus on solidarity and team sport. I think that's hugely important, and only together, and I know the DG from WHO has said this quite a bit, only together will we advance quickly and kindly together and efficiently. And when I say efficient, it's like what we do want to do, like we've been doing this whole pandemic, is try to find the answers as quickly as we can so we can better care for patients, and optimizing the use of previous platforms, which is a common theme that we've heard during this forum, is hugely important. So previous platforms for other diseases or other that have been successful in finding answers quickly. Quality, so quality in design of studies, quality so that we can generate evidence that is reliable and accurate. And I think the quality here is wide-ranging. It's patient-led research, it's community-based research techniques. It also includes observational studies and randomized controlled trials. So again, and the basic science. So we need to look at how can we generate this evidence quickly across the spectrum, including looking at treatments for early interventions as have been described. And finally, service. Patients need to be cared for now. So that means we've been talking about the multidisciplinary, and I won't go into all those details, but I wanted to highlight patient-centered care, right? Just like we do for any other disease. So it's patient-centered care. We may not know all the pathophysiology yet, but we know some of the symptoms, some of the limitations. We have to address those with multidisciplinary approach, with rehab, with primary care, with the specialists, with the mental health groups, and ensuring that the patient-centered care includes the care for the other chronic diseases, as has also been said many times, and includes the care for children. So with that, I just want to thank you for this great opportunity. And from the perspective of WHO, we've learned so much from everyone sharing their work, their experiences, and we do look forward to continuing this important work together as the start of the new year. So with that, I would like to hand off for the meeting wrap-up and next steps to Professor Charu Kaushik, and as well to Professor Peter Horby. So over to you, Charu and Peter.
Thank you very much.
Thanks very much, Janet. So I guess I'm going to invite Peter to give his closing remarks.
Great, thank you. Thanks, Charu. Really, I think this has been a very inspiring meeting. It's been great to have a meeting that's been co-organized by patients, by a network of funders, and by a network of researchers. It probably isn't the first, but it's my first, and it's been really great to everyone's together because we can listen to each other and hear the different perspectives. The funders wanting to fund useful research, the researchers wanting to do high quality research, and the patients wanting solutions to their problems. And I hope, as well as listening, we've also heard. We've heard what's been said, and I'd like to particularly thank those who've stepped up and spoken and given videos when they may be unaccustomed to that. Us academics are used to talking about ourselves. In fact, often you can't shut us up, but it's been really lovely to hear the patient voices. And for me, that's been the most inspiring part of this. And I'm really looking forward to taking this forward as a real partnership to see if we can co-develop a research agenda and also solutions for the problems, and trying to do that quickly and together so that we can come to an understanding of long COVID and how to prevent it and how to treat it and manage it.
Thank you, Peter. So my job is easy because a lot was summarized in the previous session in terms of what the patient perspectives are, what the researcher perspectives are, and what the funder perspectives are. So as Peter very aptly said that when we conceived this meeting, the thought was that we need to hear from people who are suffering from the symptoms and are not being recognized. We need to talk, bring them together with researchers who are working on this. And then we need to bring funders who can really hear both of those voices to see where public funding and other funding is best invested. So I think from that perspective, this has been a really successful workshop where we have clearly heard, and I'm from the HIV world, so as others have said before me, listening to patient voices is always a touch of reality for academics who think about researchers and multi-system research, etc. So I will not go into great lengths of detail, but clearly we heard probably the clearest questions from the patient groups and the patients themselves. Everything from the issues of stigma and not being recognized. Regardless, it was surprising to me that whether you're in Netherlands or in India or in Greece, the struggle to be recognized that you're suffering from something that people need to recognize. The fact that many of these people are actually from the group that was not hospitalized, are PCR negative, that need to be recognized. Very moving accounts of children and long COVID suffering children, mental health issues. So clearly these are very clear messages that we heard. The heterogeneity and complexity of the disease, the symptoms, and the very altruistic intentions of patients that they are suffering from what they're suffering, but how can we prevent from creating millions of people more who will be suffering this over next few years, if not for longer time. So we really need to move on this fast so we can actually prevent that from happening. So I think those were really great, sort of themes that we touched upon. And I think Yazdan and Jean-Marie covered very well sort of the perspective of the funders in terms of listening to the patients, patient-centered research. Janet talked about that, it's a multi-system disease and multi-system symptoms. So we really need to listen to patients in terms of how to prioritize and go about moving forward with this. So I think our jobs are clear. We need to put together what came out of this meeting. We heard very clear messages from this. So I'm looking forward to putting together with the team that has been working here on the what the meeting outcomes are. And finally, I'd like to finish by thanking everybody who has participated in this meeting, starting with thanking Dr. Tedros, who took time from his extremely busy schedule to come and acknowledge the voices of patients and how important this topic is, and our other WHO colleagues, Janet Diaz and others. I want to acknowledge on behalf of GloPID-R ISARIC partnership. It was excellent partnership along with the long COVID support group. Great to bring these different groups together, remarkable success on how we can zoom in on important issues. And then I would be amiss not to acknowledge the wing beneath this whole conference, Dr. Gail Carson, who has single-handedly, put together. It was her idea that she brought to both ISARIC and to GloPID-R, and she has been really sort of the conduit of putting all this together. So on that note, thanks everybody. It's great to have this meeting, and you will be looking forward to what comes out of these meetings. Peter, any last word?
No, you said it all, Sharon. Thank you very much, everyone. It's been great, and we look forward to the next stages.
Thanks, everyone. Have a good day and stay safe.
Hello, I'm Elisa Perigo. I'm a patient and a researcher, and I'm here to say a couple of words about the birth of long COVID and why long COVID matters. Long COVID is a patient-created long COVID. Long COVID describes a longer and more complex course of illness than that which was coming out from early report from China and policymakers at the beginning of the pandemic. And last winter and last spring, thousands and thousands of people were falling ill with COVID-19. They were not recovering, and they were left at home, sometimes to die with no medical care. So they started to come together on social media to share their experiences. They started to speak to newspaper, broadcast media. They started a grassroots campaign for recognition. They started their own research reports. In these early findings from patient researchers are now being replicated in biomedical research. Long COVID came into being as a Twitter hashtag in May 2020, and soon it became quite popular, not just among patients, but also among the media, medical professionals, and policymakers. And only 3 months after its appearance on social media, long COVID was used in the landmark meeting between advocates and the World Health Organization of the 21st of August, which recognized the long-term effects of COVID-19. But long COVID is not a single organization, a single person, a single nation, a single research group. It is a grassroots movement of people who came together in solidarity to ask and to provide for care, recognition, research. We really need to keep using long COVID. Long COVID is a testament to those who fought for it, even when they didn't know if they were going to die or to live. It is a testament to patient activism and agency. It's really good to bring attention to the sometimes devastating long-term effects of COVID-19. It is good at keeping research optional and definition open when we still don't know that much about long COVID and COVID-19 natural history and development. But it really goes beyond the COVID-19 pandemic. Long COVID is the voice of patients, and the voice of patients have often been marginalized in healthcare system, biomedical research, and medicine more in general. And this is especially the case for the voices of women, the disabled, and those from marginalized and minoritized community. And now that we have this new collaboration between medical professional, researcher, and patient, we really need to keep going in this direction to make medicine better and more attentive to patient. We really need to listen to patient voices and expertise in the year to come.